Good morning, everybody, and welcome. We are the NHS Lancashire and South Cumbria Integrated Care Board. It's the 5th of July. Good to see everybody. I have apologies this morning from Angie Ridgewell and David Levy, who are members of the board, from Vicky Gent, Kath Worley and David Blacklock, who participate in our meetings. As our friend says, today marks the 75th birthday of the NHS, the first anniversary of our integrated care board, and I think it is, listening to the radio this morning and all talk about the NHS, what it stands for, what it does, the context in which we operate. It is a moment for us to reflect, most importantly, I think, on what the National Health Service stands for. We all today play a part, but essentially, whether it takes us a long time or a short time, we're all passing through. But while we're here, we are important as the custodians of the values of the National Health Service, and mindful of the very rich and important history it plays in this country. 75 years ago, we wouldn't have imagined the way the service operates now, the technology that supports the work of all our staff, the very different demographic of the country that we serve, the demands on the service. But throughout all of that, the way in which all people contributing to the health service, whether you're blue collar, white collar, green coat, white coat, whatever the uniform, whatever the role you play, you're part of something that absolutely matters so much to the country. And on days like today, it's important to remind ourselves that in this period that we pass through, that we do our work to the very best of our ability. We do it properly, and we do it in the right way based on the values that have been consistent throughout the life of the service. Not just about public service generally, but in the care and compassion and empathy that we connects us with the service, with our patients, with our communities. We've staff out there working under incredible pressure again every day. It's been a rough time with the pandemic. We're now facing unprecedented levels of industrial action. The service never has an easy day. And part of our role in boardrooms like this is to do our best to create the conditions and to support our staff providing care on an everyday basis to be able to be the best that they can be, and we should keep that in mind as we go through our business today. There's I think a formal service in Westminster Abbey this morning. I attended the one, I think it was the 60th anniversary 15 years ago. And the thing that I remember most vividly about that service, there was a nurse who had been in Guy's Hospital, I think started pretty much close to the first day of the NHS, being formed, telling her story about how all that works. And I do think that being mindful of the history and the people who've gone before us and the contributions they've made helps us get what we do right. So that's the important context for our meeting today. The core of our discussion will be around both the integrated care system joint forward plan and then the place integration deal. And we're joined this morning by Claire is here. I've seen Louise is here also, and Karen. Thank you. Hi, Karen. So they'll join us at that important part of the discussion. The declarations of interest, normal rules apply. If you feel conflicted at some point in the discussion, please make us aware of that, and we will manage it accordingly. We've two sets of minutes to consider and approve. Our board meeting on the 3rd of May, and then the extraordinary meeting around the financial year close on the 21st of June. If we could first look at the minutes of the 3rd of May, please. I don't think there's anything, Kevin, that we need to pick up that isn't elsewhere on the agenda today. Are we content with the minutes of that meeting, please? Thank you. Agree. And then in the action log, it highlights for us when items will come back to the board, follow up from previous patient stories in particular. The meeting then on the 21st of June. Jim, can you just update us post that meeting about where we got to in the final closure and sign off of both our predecessor CCG and our first year accounts, please?
Yeah, thank you. All the accounts have been submitted, not necessarily in the right order, but they all. We did have some practical problems towards it. Not from our perspective. It was rather difficult to get some of the audit sign-offs, but we got there in the end. The team worked incredibly hard to do what they did and to get the final accounts in on Monday this week. So everything's in. It was all discussed with the centre beforehand, so they were aware that there was a slight delay. They were comfortable with what was going on, because I think we were not unique in terms of having problems. What we tried to do was basically to complete 9 sets of accounts in one go, where normally we'd be completing 1. And we had some problems with some of the former CCG accounts in terms of signing off some of the details. But we got there in the end, and fingers crossed there'll be no... It should all work out fine, I think. We're not anticipating any problems. This situation should not recur in the year we're in now. So at the end of this financial year, we'll only have 1 set of accounts to close. So it was a one-off event, but we got there in the end.
Well done, Jim. Thank you. Are we content to approve the minutes, please, of the meeting? Thank you very much indeed. Kevin, straight into your report.
Good morning, everyone. So I've got a quote at the start. Rough waters are truer tests of leadership. In calm water, every ship has a good captain. And by goodness, we've been in some rough waters of late. We do face some tough decisions. We won't be able to do everything. We'll say yes to some things and no to others. And to navigate our way through the rough waters to a safe haven, we're going to have to take some risks. And we're going to have to lead from the edge, if you like, get outside of our comfort zone. And I think reflecting on our year, this time a year ago, I think it was our first business meeting on the 27th of July 2022, we made one of those tough decisions around our place-based partnerships, if you recall. We had place-based partnerships based on hospital catchment areas at the time. If you were in Lancashire County Council, you were in 5 partnerships. You were never going to be able to do serious integration between health and care in that situation. So you made a difficult decision to change the boundaries to align with the principal councils. And we took some flack in making that decision, and it slowed things down too, because it took time to get staff on board, to develop the new arrangements. But now that's happened, it's starting to gather pace, and I think it's really good that we've got a big decision for you today, which is what's the delegation program to those places going to be over the next 3 years. So that's a really significant milestone. We've also got another set of difficult decisions around money. So another paper on today's agenda is around system recovery. Again, a very challenging issue, and it's not really just about money. Underlying that, it's about reconfiguration of our system, and it's how we do things around here. In other words, culture. They're the real issues. The money is merely the symptom. Another big item on our agenda at the moment, not on today's board agenda, but a big issue for us is specialised commissioning. There's a budget heading our way. It's close to £2 billion a year. It's a very significant area. And I think it shows NHS England's serious intent to devolve things. So that's going to be handled by integrated care boards going forward. And we will host the hub for that in Lancashire and South Cumbria for the North West region. So Craig, this is one of Craig's areas, and it actually aligns rather nicely with the broadening commissioning role I'm asking Craig to take on as well. So that's really a very significant development. We're in a shadow year this year. It goes live next year, and it's something we'll probably need to take a closer look at once we've got a better handle on this area. We're in the process now of putting together a dedicated team for specialist commissioning and for that change process. It's not for the faint-hearted, this change. Effectively at the moment, the funding for specialist commissioning goes directly to the institutions. So a hospital like Christie's in Manchester would be a good example. A lot of their funding comes through this route. In future, from 24 onwards, the funding will come to the Integrated Care Board. It'll be population-based. So there's some fantastic opportunities to, if you like, to use the jargon, move upstream and do more preventative work that hopefully in future years will reduce the need for the volume of specialist commissioning that is there now. But at the same time, we're going to have to navigate and not destabilise the institution. So it's a bit of a balancing act. And we do have some challenges in the Northwest, particularly in Merseyside and Greater Manchester. There are a lot of big specialist institutions that provide services beyond the Northwest region as well. So that too is going to be a big risk area. But I think it's a compliment to Lancs and South Cumbria that we've been invited to host it. So well done. Final thing I think is worthy of comment, and Kevin McGee may wish to add to this because he's got a direct interest and involvement in it. It was pleasing to get the new hospitals announcement. On the face of it, you might be concerned that we're in sort of tranche 2 and it's been pushed back to 2035. But the reality is that was a very optimistic time frame. This is, I think, the normal trajectory for a hospital is about 11 years, isn't it, Kevin? So, you know, do the maths. You're well into close to 2035 anyway. And there's a long way to go on this. Probably the critical thing the great thing here is we've got 2 new bills, one on a site not too far from here and one on a site in the Leyland Bamber Bridge area. The key thing is that we get on and acquire those sites and use. We do have the ability under the new arrangement and the minister's announcement to get some drawdown funds to do the enabling work and site acquisition. I think that's got to be the priority. So I think that's a really good decision, and we can start moving forward in that area. So there's a lot of meaty issues on our agenda at the moment. I think some tough decisions, but also some exciting opportunities, and probably that's a good sort of theme for us, isn't it, as an ICB generally.
Thank you, Kevin. Kevin, anything you want to add about the new hospitals in particular?
Thanks, David, and thanks, Kevin. I mean, we're absolutely delighted that I think for the whole of Lancashire and South Cumbria, we've got that fixed now in terms of the capital allocations for the 2 new hospitals. I think it's really important, though, that we don't just see them as physical bills. We use this as an opportunity to really transform service delivery, both in and out of hospital across Lancashire and South Cumbria. It gives us a massive, massive opportunity to rectify perhaps some of the historic decisions that have been taken in Lancaster and Lancashire, where we've had too many sort of interfaces, too many barriers to delivery. So this is a massive opportunity to do things differently. As you say, Kevin, we'll be looking to get very early drawdown of some of the cash to enable us to do some of the enabling works. So I think this is brilliant news. We've got the budget, we've got a timescale, and we can start very quickly in terms of the transformation.
Thanks, Kevin. Any other points or questions on any of the issues that in Kevin's report or things that he's said? Okay. Thank you. Let's move on then. Patient story, please, Sarah.
Yeah, thanks, Chair. So the patient story today is slightly longer than we sometimes have, but I hope when you see it, you'll agree that it would have been hard to cut that down. So it's a young person who had a negative experience around his access to eating disorders services, but he's actually gone on to set up and chair our Lancashire South Cumbria Children and Young Persons Forum. So I think on the anniversary of 75 years of the NHS, what we're seeing here is an example of somebody whose used experiences had not the greatest experience, but he's turned that into something really positive and is actually helping us now learn from his experience. So thanks, Chair.
Hi, my name's Ben. I'm here just to spend a couple of minutes walking you through my story and my experience of the eating disorder services as a young person in Lancashire. So my story begins back in 2018, where I chose to go on a period of dieting and increase exercise in the hope to lose some weight. After around 2 years, so we're looking at about 2020, I began struggling with my eating issues, and myself and my family found that I'd moved away from a diet and it was now presenting itself as an eating issue. Over this period of around 2 years, I lost 5 stone and 4 pounds, and my BMI fell to around 18, which placed me in the underweight category. Now, before the first lockdown, I was in a period of weight maintenance, but unfortunately, when we went back into lockdown, I was struggling again with losing weight, and I was also presenting with a deterioration of physical health. I was feeling cold, I was feeling fatigued, and I had a loss of concentration. So in June 2020, I was age 16. I made an appointment with my GP at my local practice to express these concerns, and this was via a telephone call, and my mum was on the call too. Now, my GP explained that I was at a difficult age, and I was told that I was too old for children's services and too young for adult services for eating disorders, and it was explained that the referral may not be taken on. Now, this made myself and my family believe that there was little hope and that a private dietitian may be the only way forward. So I went ahead and I booked a call with a private dietitian. Now, in the meantime, over a period of about 3 weeks, I received an assessment letter from the eating disorder service. So I had my initial assessment, and then I was given an extended second assessment, which took place in early September 2020. After the second assessment, I was discharged from the service, and I was told that they didn't feel that it would be helpful to bring me into the service at the current time, and that I was focused on getting back to sixth form. Now, this is a decision that I disagree with, because I was simply left to self-recover whilst in full-time education and had no support. Now, around 6 months later, I was applying to university, so we're looking at March 2021. And I was looking to put support in place from the University Health Service. And this involved a form which needed a signature from a medical professional. Now, I contacted the East Lancashire Eating Disorder Service on 4 different occasions, by email and by phone, but received no response. It was only when my mum contacted the service that my mum was told that they would not sign the form as I'd been discharged from the service and I was no longer on their records. I then contacted my GP to ask the same question, and I was told that signing the form may be a chargeable service, which I found quite shocking as I was still a child at the time, at age 17. Now, the day after this, I received a telephone call from the eating disorder service, which explained that they may be prepared to complete the form, but it would need to be decided on within their management meeting. I found that the whole process of trying to get this relatively simple form signed felt really dissatisfying and below the standard expected by sort of my healthcare professionals. And in the 6 months post-discharge, so from September 2020 to March 2021, I came to realise that my self-recovery efforts with absolutely no input from the GP or the eating disorder service just weren't sustainable, and that I just needed some further assistance. So to shine a light on the issues that I've discussed and to request further help, I made a formal complaint to East Lancashire Clinical Commissioning Group, expressing a serious concern for the provision of eating disorder services. This was submitted on the 16th of March 2021. Now, unfortunately, I failed to receive a response from the CCG, so I followed this up on the 22nd of March. On this date, I received acknowledgement of the complaint, and I also received an apology for the complaint not being acknowledged in the widely accepted 3-day window. I was then allocated a complaint handler who worked with my GP and myself to ensure that I could have the form signed, and this was actually done the same day. And I was also helped to make a self-re-referral to the East Lancashire Eating Disorder Service. Now, I really want to express a huge thanks to my complaint handler who went above and beyond the normal practice through regular phone calls and keeping in contact to attempt to improve future experience of my use of the services. Now, as I was passionate to ensure that other young people didn't experience the same issues, with my permission, the complaint handler linked myself into Health Watch Blackburn with Darwin to share my story. Health Watch then linked me in to the Prevention and Engagement Lead at Lancashire and South Cumbria NHS Foundation Trust. And with the Prevention and Engagement Lead, I've now used this negative service experience to attempt to improve service experience for young people going forward. Thanks very much for listening.
Out there, we know we've got waiting times and challenges in eating disorder services that need addressing. That's a national issue, but also he brought out the often at times disjointed state of services and how we're not very joined up, and hopefully the work we're doing at Place and the work we're doing as an integrated care board to come together, integrate all our teams will start to address some of those issues over time. And poor communication often comes out as well as a challenge in stories like Ben. But I think he also brought out on the birthday of the NHS, it's often people in the more hidden roles like complaints handlers who actually often really have an important role to play and help patients and users of services to navigate. So I think it's important we celebrate those people in those roles as well as frontline NHS staff. But so lots of issues there. We had a long discussion about this story at Quality Committee, but lots of teams are working with Ben and through his experience to try and take learning from that and address it. But I hope you all agree he's doing really well. He's at university, very articulate young man who has actually turned something negative back into helping the NHS move forward by listening to his experience.
Thank you, Sarah. Chris, and then Debbie.
Thank you, Chair. Thank you, Sarah. So yeah, as Sarah said, Ben is really articulate. He now chairs Youth Voices for NHS England and has really helped the organisation with that service user voice. And he wants to work in a career in the NHS in finance when he leaves university. So it's got a really bright future ahead. Just going back to the eating disorders, which is the service that obviously Lancashire Cumbria Foundation Trust provides across the full geographical footprint. Back in 2020, when Ben was accessing service, it was a fragmented adult and child service. Following a full service review late 2020, it is now an all-age service. It links in with various voluntary sector organisations as well for signposting, right the way through to high-level intervention. Back in 2020, the service wasn't meeting any access standards for eating disorders. It's now fully compliant, both for adult and for children, with routine and with urgent access. So a real success for a service redesign and improvement on the back of patient feedback. So absolutely is, as Sarah said, still huge demand for eating disorder services, especially after the pandemic. It was the fastest growing demand service post-pandemic for NHS, but a good service level of service delivery now within Lancashire and South Cumbria.
Thanks, Chris and Debbie.
Thanks, David. I think that's really helpful to hear. I think all credit to Ben that is using his own experience and sharing it to try and get that service change and improvement. So Really enjoyed hearing the story, but obviously heard his frustration, which completely acknowledge and helpful to hear about how things have improved. I guess there's two things for me, and you've kind of picked up, Chris, about the challenge around that interface between young persons and adult services, and how previously perhaps people got a bit lost because they were kind of caught in the middle. I think the other interface I'm just interested in hearing about is if there's a challenge around the interface between your community service and when people need to access acute support, and how sort of that's working, because from experience and other feedback in other forums I've heard that's the other interface that can be quite challenged when young people become so poorly they have to go into an acute setting, and how does that work and them transfer backwards and forwards. So it'd be helpful to sort of hear that view. And then the other point was just, it's picking up what Sarah said about complaints and the rich intelligence and understanding and the value of that service, and the skills of those people in actually producing solutions when they know that there's issues around services. And it's, is there anything else that we could do or we should think about as a board to support some of that? Because again, from experience, those people handling those calls get some fantastic insight, and they have to work almost a bit under the radar, working across teams to get some systematic change. So are we doing as much as we can do to facilitate that and get the difference in the services through that route?
Thanks, Debbie. I'll collect up a few more points, then come back to Chris and to Sarah. I've got Jeff, then Asim, then Jim, then Tracy.
Thank you, Chair. Picking up on the transition, this is a real problem for various services. It does tend to be more the mental health aspects, but it's not unique to mental health. And patients and GPs struggle with this. And I'm going to make a suggestion, and that is because often what happened to this young lad happens, oh, you're not going to get seen, you're 17, you're not going to get seen by the time you're 18, so we're not going to refer you. And then you wait till you're 18, and then you're going to go onto a waiting list. Actually, what should happen is that person should be referred, and then their position on the waiting list should be acknowledged by the adult service. So if they've been waiting a year, they should then slot in, not at the beginning of a waiting list, but higher up the waiting list because they've already waited a year. And we should require that as a commissioning process for all services, and just say, you've waited your reasonable time, you're now going into, not the top of the list, but whatever is appropriate, and some calculation of how that's done. But it's not fair the way it happens at the moment, and it does carry risk.
Thanks, Jeff. Very helpful. Asim, then Jim.
Thanks, Chair. I think Ben's story makes some really important points, and having worked in mental health services for the last 10 years, these experiences not uncommon, but we can see a lot of improvements are being made. I just want to make a couple of points. One is the important role of digital in this area, whether that's e-referrals or video consultations. But more specifically, across the country, there has been real good examples of digital platforms, online social platforms, which makes use of people with lived experience, families with lived experience who have been through some of these journeys. And the evidence is really powerful. It's showing how people can access these services while they're waiting to see a consultant. And when they're discharged, they've got something to fall back on. So it's helping relapse and readmission prevention, and is giving young people something to fall back on when they go into university. So something absolutely we should be exploring within our areas here as well. The second point, which is a more general point, eating disorders historically has been associated with white young female, but this eating disorders affects all demographics, all ethnicities at similar rates. Maybe evidence is showing it's affecting some other demographics in an increasing rate. And in some of our communities, this stereotyping and stigma sort of has challenges. And in some of our communities, these conditions are dismissed or denied. So there is, I think, some specific interventions we need to do. And linking back to the first point, there's some emerging evidence that digital solution and channels are more appropriate for people from these communities because they feel anxious to maybe enter into a service. So just some general points, but really some good points I think we can definitely look at and take forward. Thank you.
Thanks, Asim. Very good. Jim, then Tracy.
Thanks. A couple of points. First of all, very eloquent presentation, and thank you for presenting that. That was really good, and I'm delighted the guy is kind of doing well at university, and I think he's made a very wise choice to think about working in finance in the NHS, but put that to one side. It was assuring to hear from Chris that the eating disorder service is kind of getting where it should be, so that's really helpful. The comment I was going to make was similar to what Jeff made, actually, which was that this thing, which you often hear, too old for children's services, too young for adult services. And it feels like, yeah, we need to look at for eating disorders, but there's a whole range of services where that applies. And it almost feels like we need, at some point, to do some sort of stock take and see where we're at as an integrated care board, and see which services we need to try and focus on and improve the facilities for, basically, I suppose, adolescents. There's an age group where people almost get missed out because they are literally too old for children, too young for adults. And it just feels like, if it's a takeaway from this for me, that it's looking into the services we provide for that age group.
Thank you, Jim. Tracy, and then Sheena, then I'll come back to Sarah and or Chris to sum up.
Thanks, David. Yeah, thank you for bringing that story. I think Ben was, as people have said, very articulate, and I think it highlights for me how important it is to listen to people with lived experience of services. I think really great to hear that things have changed since then, but I think also there are still people falling through the gaps in these services. And I think, I'd like to pay tribute to Health Watch, who Ben mentioned as a service that really does help people hold us all to account in terms of how people are accessing services or not in some cases. One thing I wanted to particularly pick up on that Ben highlighted is medical evidence and the fact that often people are charged by the GP to have evidence of their medical history. It's something we see at Citizens Advice day in, day out, particularly when people are applying for benefits where they need medical evidence to prove that they're eligible for benefits. We actually, in Blackpool, often fund this. Sometimes it's £25, sometimes it's as much as £45 for a letter that provides that medical evidence. I think that system needs to change. I think where people require that to be able to do things as basic as access services in the way Ben described, or claim benefits, which is obviously very vital to people, I think we need to look at that and scrutinise what's happening across the board. So I'm really glad Ben highlighted that. And I think similar to Asim, who's talked about digital, I think also we need to look at all those wraparound services that exist in the community. So again, drawing on my own experience in Blackpool, we have a children and young people's social prescribing link worker who is very much supporting people as they move in and out of services, holding their hand, picking them up when they maybe get discharged from certain services, to provide that kind of continuity so that they don't fall through the gaps. Again, I think more investment in those kind of things is needed, and I think Ben highlighted that. Thank you.
Thank you. And Sheena?
Yeah, thank you. I'd just like to pick up Asim's point about taking a population-based health approach and link it back to the opportunity there is around Lancaster South Cumbria taking on the specialised commissioning role. As I know in the work that's gone on with specialised commissioning with eating disorders, because it's now taking a population approach, work has begun on the very things that Asim very helpfully points out around understanding why it is that certain communities don't access services, and actually coming alongside those services to seek to understand why that is so, and then thinking about how does service redesign ensure that everyone who has a need can access services effectively. So I think it's a really good way of actually saying, if you start to take a population-based approach, you can do that, and also sitting in partnership with people who have the lived experience and also have the connections into the communities to understand why it is that people are reticent to come forward, why services aren't culturally appropriate, and actually doing that change that's there. And I think the other bit on that that's really important is the work that people have already described about working with the third sector, with organisations like BEAT, who do some really great work about actually using the lived experience to help shape service redesign in the way that Chris beautifully articulated about what's happened since Ben's experience, and what a great inspiration Ben is, and what a great person to have doing our patient story on our 75th anniversary of the NHS, and it makes me feel very positive about the future that we've got people like him who'll be part of it, and that's already making a big difference. So
Thank you. Very well said. Sarah or Chris on some of the points that have been raised?
I'll answer on the ones around complaints, and that Chris might want to comment on the one around acute admission. So in terms of the complaints team, it's a really valid point. We've got a very small complaints team, just grown a little bit because we've in-housed some of the complaints function as we've brought in more primary care from NHS England. And to be fair, that team, just so people understand, are part of the quality clinical team. So they are very much part of lots of the meetings and discussions we have around pathways. And as you'll know, they do feed into PIEC, and complaints do feed into quality committee. So I think we are using the intelligence that's coming through our complaints to triangulate the work we're doing. But I will go away with that and look at sense check, can we do more? But I know we've got some really excellent people in that complaints team who are a lifeline to some of the individuals when we get a number of complaints on the same theme. They do work a bit like Ben's experience there, go above and beyond to help people who have chosen to complain to navigate the complex system. I think the points on transition were really, really important. A lot of work has been done on transition of children into adult services, but I think you're absolutely right, more can be done. There are areas of services now that are moving to more all age, the way Chris describes, so things like continuing healthcare, which people can need it as children and then in adults, and moving to an all age service. But I think there is more we can do. So again, I will take that away and work with both the children and young people's team and some of our adults team to make sure we're really looking at transition across. And I think the point that Jim made around understanding where it is, because it does vary. Some of our children's services will take young people to 16, some will take them to 18, and it does cause challenges for different clinical specialties, and it varies sometimes even across clinical specialties. So it is something that we need to take away and I think do more of a focus on. So I think and I think we need to take examples like the social prescribing in Blackpool, and sense check, is that happening in all of our places? And for me, when we get the place presentation, it's things like that are a place about how do we make sure that people living in our communities are being helped to navigate what can often be a complex system around health services. Thank you.
Anything you want to add, Chris?
Yeah, I suppose just a few things just on that navigation. So within Lancashire and South Cumbria, we've now got the initial response service. So one number for any mental health concerns. We've got it across all areas except for Blackpool, and that will be going live later this summer in the autumn time. Just coming back to Sheena mentioned about BEAT, and we are linked in very heavily with BEAT as a accredited voluntary sector organisation that nationally support eating disorders. And that's part of our model. And as Sim mentioned around communities and that engagement piece, so we've commissioned Yvonne Coghill, who was the previous NHS England director around race equality, to do a piece of work around communities as well, and that's coming to our trust board tomorrow, how we make sure that we're getting into communities and really hearing the voices and access for service. The piece around acute admissions, so within Lancashire and South Cumbria we don't have inpatient eating disorder beds, and the criteria to get into those out of area inpatient eating disorder beds is very strict. So we do see at times, quite often, children especially on the paediatric wards within acute hospitals requiring quite intensive mental health support around that. Sarah Cullen, so Kevin's chief nurse, worked quite closely with our organisation around how we can do that and make sure that we're providing the paediatric staff with that support. That is still a challenge. I don't think we've got that nailed yet, but it's 100% better than what it was, and I think the relationships with that are with the paediatric teams and the mental health CYP teams is only going to improve. And in addition, through the investment from the ICB this year, we've seen our home treatment teams for CYP. So we've now got home-based treatment teams that will go out and see people in their own home to try and manage and I suppose stop that admission, to make admission only when it's required. But I don't know if Kevin wanted to add anything around that acute intervention, Chair.
I mean, just very briefly, it's an issue that we absolutely recognise, and Chris has quite rightly talked about the relationship between the paediatric teams and his teams, and they do work much closer together now. They recognise that interface is not as strong as it is, and the relationships are now really strong. So we just need to keep working at it and building up the relationships and building up that trust between the teams, which is now starting to develop.
Thank you. Thank you all. Two action points I'd like to add to this. One, this issue about charging for letters. I'm sure there's arguments always around the rights and the wrongs of that. But it seems to me, Kevin, that consistency is an important issue. You know, what our expectations are and how we support that through the piece. It would be good to get some follow-up on that. And the other thing, bearing in mind on the story, the complaint handler at the CCG was crucial to the whole thing. Then are we assured in the way that you describe we have an ICB team that all the sort of live issues at the point that the CCGs ended and the ICB started get picked up? Was the risk that cases fall in the organisational gap at that point, Sarah?
Thanks for that question. We did manage that transition, and just so people understand, so there was only one CCG that had an in-house complaints team. All the other CCGs used MLS CSU. So when we created an integrated care board, we brought the in-house CCG team and the staff that were working as part of CSU together as one team, and we tracked all the complaints that were live in those organisations. We've actually, 1st of July, in-house now the CSU team, so we've now got one integrated ICB complaints team, but the individuals that were working across before, a lot of them are the same individuals, but we did track and we did transition all the live complaints that came over, and it was a year in. I've not had anything flagged that was anything missed.
Okay, well done. That's good. Thank you. Right, let's move on now. A very good discussion, a very good case study, Sarah, and a good discussion. Thank you. We've got the minutes of the meetings, and we're now getting in more 1 year on, more into a rhythm of a lot of the detailed business being done in our committees, and we're working hard with the committee chairs now in getting the right issues escalated into the board. As we see through the sort of 3A reports, the alert, advise, assure reports, we're still working on getting the consistency on that. But I'm going to ask each of the committee chairs now, if there's in the alerts, if there's anything that they want to highlight to us now that we can flag for further agendas going forward. Sheena, can I start with you, please?
Yes, thank you. So what the board has in front of it today is the report back from two meetings. The first of those is the 17th of May, so I'll pick out the alerts from the 17th of May. And what we wanted to just bring to the board was a number of things, and one was around the quality impact assessments. Now, these have been undertaken, but in undertaking those, what the teams have been doing that have identified that we need to have a more consistent way of doing that and making sure that that we have that done in a way that actually looks at the current policy and how do we further improve that. So that's part of the learning exercise. So it was really just making sure that the board was aware that that's something that's being further refined and developed in that learning way. Interestingly, having just talked about issues about children and young people with mental health needs, we just wanted to again bring to the board the issue about the unfortunate longer waiting times than any of us would wish around those services. And that is really a combination of things. Part of it is an increase in demand in the way that was identified in the patient's story due to the context that people are living there, have been living their lives in, but also around workforce issues. So we are taking a very close look, and the CYP and Learning Disability and Autism teams are undertaking review into the current pathways and to work in the meantime working along some providers to mitigate the risks associated with the long waits. And those were the two items. There are a couple of other things that are there, which board members, I'm sure, have been able to read. If it's okay with you, before I offer any questions, I will just then take us into the alerts for the second meeting, 21st of June, if that's okay with you, Chair. So the next items was the 21st of June, and you'll see that there's a number of things there, again, that wants to pick up. So the first of those was around maternity services, which is around really just describing whilst an awful lot of work's gone on maternity services and things are moving positively forward, what we just want to bring was the fact that as we know, for a number of areas at the moment, workforce is a challenge in terms of recruitment, but there is work going on in trusts with the ICB to mitigate the risks and to think about how to look at some of the things that are there in terms of thinking about retention, recruitment, further development of roles to help support that. And obviously there are challenges as well in terms of making sure that the money that comes into the system for the development of maternity services does come out in a timely way. And again, that's something that is being picked up. The next item I really wanted to pick up from that was around dental contracting and service provision. So this is something that's new to the Quality Committee. We had our first really comprehensive look at dental access. We had a really, really helpful presentation that looked at what the issues were. But I think just as importantly, or probably more importantly, what was the transformation and the thinking that's being done to think about how can we find some of the solutions to some of the issues that there are in the provision of dental care for the people in Lancs and South Cumbria. That work will be overseen by the Primary Care Commissioning Committee, and that we'll be bringing back progress and understanding that plan to the January, probably more likely the February, just looking at the timescales for that and making sure the work's got the time to be completed. But that is something that I think is be really important to bring back, probably as a particular item to the board more formally when we've got the outcome of that. And that was really all I just wanted to bring from the alerts that are there. Thank you, Chair.
Thanks very much, Sheena. So I think as you flag the access to dental services will come out. Also, just reflecting on the piece about maternity services, I know you're focusing specifically about the workforce issues, and when we get the people board, I don't know if Ibby or James wants to talk about if we've got a particular focus on some of the maternity workforce. But at an early meeting, we talked about the Ockenden report and the conclusions and recommendations therein. I just think it would be timely 1 year on for us to have a stock take around maternity services on the patch generally. Sarah, if you want to think about the right time to do that, please. Thank you, Sheena. People board, Ibby?
Yeah, thanks, Chair. That's really helpful that we are approaching workforce from a number of different perspectives and committees. What's also really helpful in terms of some of the alerts that we've identified is that the system of cross-referral from one committee to the other is working quite well. So it's the Quality Committee that flagged up that there was low uptake by staff regarding COVID-19 and flu vaccinations, and we're picking that up as an issue at the People Board. There's two areas that we want to bring to the board's attention in terms of alerts. One is that we are and have focused on and are probably much clearer around workforce succession planning for our provider organisations. That is not as mature for primary care and social care. So as a People Board, we're turning our attention to that because there are clearly risks in both of those areas in terms of the way in which that then affects system performance. We haven't picked up maternity specifically as an item, but on the back of what Sheila's just mentioned, we will do, I think, a deep dive into that from a workforce perspective will be really helpful. And the other area is we've also been thinking about the FTE reductions that are planned for the 23-24 period. And we just want to be real clear about how that is done and delivered in a sustainable way. So again, we'll be an opportunity there to interface with Sheila again from a kind of quality perspective. So those were the alerts from the meeting of the People Board on the 24th of May, Chair. Thank you.
Thank you, Ibby. And James, anything you want to add?
To add on top of that, a number of the issues that Ibby's raised and People Board have raised have also been surfaced on Friday with the nationally with the publication of the long-term workforce plan, which some of you will have seen the Prime Minister and others speak about last week. So it's a pretty kind of monumental plan that's been delivered. The first one to take us to plan workforce numbers for the next 15 years. We heard, I attended a session on Monday morning with Amanda Pritchard and the Deputy Finance Director for the NHS. So we understand that there is 2.4 billion of investment to go into it. So we've got, the People Board will be taking a really clear look at that plan. We have just started a significant piece of work to develop a 5-year workforce strategy for the ICB. So we'll be utilising that to really follow through on the kind of directives from the long-term workforce plan. So lots to be done. That will come back, Chair, to this committee for approval.
Thanks very much, James. Finance and performance, Roy?
Thank you, Chair. Just refer to the alerts, as other people have done, for the 11th of May 1st. Of course, there is a finance paper on today's meeting, and I'm sure that will supersede some of the issues that I'm going to just refer to. We did talk about the 23-24 planning update and the assumptions, and the committee did note the high level of risk in our 23-24 plan in respect of those savings and those expectations. So for the ICB, a financial sustainability group has been established. That reports to the committee. It's co-chaired by the Chief Finance Officer and the Chief Nursing Officer. And that's going to review all the schemes and provide a monthly deep dive into high-risk schemes for us. I just wanted to refer to an advice that was in that committee as well. I know you talked about alerts, Chair, but I'll just refer to this, that we received an update on the final year-end position of 2022-23, and the ICB did remain at their break-even position, and the final provider position was a £49 million deficit, but that was supported by the brought forward surplus and some allowable adjustments. We did have a meeting on the 26th of June as well. There is no AAA report, of course, on today's meeting, as it's not been prepared yet. But I just want to refer to a couple of items that we talked about on there. We spoke about, Chair, a particular issue regarding diagnostics that the board and indeed yourself had asked the Finance Committee to look into on behalf of this board. I think it's really important, actually, that it was specifically referred to, I think, cancer diagnostics and the possibility of mutual aid, I think, across hospitals to gain a better patient experience, I think, of receiving diagnostics for cancer treatment. We were actually assured that a piece of work has been commissioned to better understand the diagnostics, and Roger Parr confirmed to us that this was being done, and we were going to get an updated report on that at our next meeting. So hopefully that will then come back to this meeting. I did actually ask about not specifically cancer diagnostics, but diagnostics per se, and referred to a particular example where in Blackpool we had received some mutual aid from ELHT for patients who needed breast screening for diagnostics for breast cancer. And that wasn't about patients actually going over to ELHT to receive that treatment or to receive that diagnostic treatment. It was for those radiographers, those radiologists that ELHT were able to share with us, for them to come over to Blackpool and see the patients in Blackpool and not for them to have to travel. I think that's really important, actually, because I think if we're going to ask for mutual aid from hospitals, it's about patients being able to get that treatment in their own area, and for those, if there is spare capacity, for that capacity to be able to come to the hospital where they're most needed. So I think it was a really rich discussion that we had with regards to that in that committee. So that's taking place, and hopefully we're going to move forward with that reasonably quickly and fairly quickly. I would also refer to, Chairman, excuse me, just looking sort of through the draft minutes here. The performance report, we talked about 12-hour waiters in the performance report, and there was some concern, I think, about the number of 12-hour waiters that we've seen in our A&Es across Lancashire and South Cumbria. And we wanted to pick up a deeper dive on this at our next meeting. And I think, again, very important. But the discussion, I think, talked about the waiters, and that the majority of those would be people with mental health issues. And I think it was really interesting to hear, I think, that as I say, that patients who had those mental health issues were waiting longer in A&E, which I think concerned all of us at the meeting. And we asked if those figures could come back to us at our next meeting, a split of those figures of people who are waiting for physical or for mental health consultations in A&E, so we could recognise, I think, what those figures were and if there was an actual issue with mental health waiters in A&E. I think anecdotally we think there is, but I think we need to have that information, so that's going to come back to the next committee. I'll stop there, Chair, and ask and await any questions if anybody's got
Thank
any.
you, Roy.
Okay.
That's very good. Primary Care Commissioning Committee, Debbie, please.
Thanks, David. So in terms of alert, there's 2 alerts that we've raised. The Primary Care Commissioning Committee, as you know, is operating under new terms of reference, and I've picked up the chair of it. And since that point, we've had 2 internal development workshops, and also our first Part 1 and Part 2 meetings in public, with the next one to come at the end of the month. So we are moving forward at pace, which is really pleasing to see. The 2 alerts, one's around membership, so we're not quite complete around membership yet, so it's really important that we're able to progress that quickly so that we've got full capacity in place and full input from participants, and also 2 members who need to join. The other point, it's really funny, isn't it, when things are written, it's very sort of vague, so it says general capacity would be kept under review. The point there is that we've focused quite a lot on the assurance framework that needs to be in place so that the committee is able to assure board that everything that needs to be done around these delegated budgets is done correctly at the right time with the right assurance. So we have had a focus on that, and through that process what we've done is we've agreed an assurance framework, and we've also established some subcommittees beneath the Primary Care Commissioning Committee to do the more detailed work that looks at the 5 delegated budgets. So the point there is just around assurance that we need to be clear what's delegated where, who's doing what, how it fits, and the assurance that's in place. And it's very pleasing that there'll be an internal audit by MIAA, which will help give some assurance around that moving forward on these new arrangements. So very much welcomed.
Thanks, Debbie. Jim, anything you want to add from the Audit Committee?
Currently not a formalised structure. That was worrying, because that's a here and now issue. That's not one for the future. That's something that we need to put right pretty rapidly. So you can see the action. We asked the executive team to review it and refer the matter on to the Finance and Performance Committee, and it'll come back to the Audit Committee. The Audit Committee don't meet till September, but we're hoping something will be in place before then. what I would say, though, is it was explained at the meeting that the situation was not as underdeveloped as was implied by the internal audit comment. But we're talking about a lot of money. Kevin's mentioned about specialised commissioning coming to us as well, with another £2 billion. We do need to have a very strong structure in place to oversee these contracts and to manage the contracts.
Yeah. Kevin, you want to?
Yeah, look, just to give you a little bit of flavour in terms of where we are and what's been put in place, and I think it's definitely a work in progress, Jim, and it does need, at the right time, it does need some check and challenge as part of that process. So I think what we inherited was extremely fragmented. It was very tactical and micro in terms of approach. There's almost no strategic contracting and commissioning going on, and very little macro. We've got massive variations from the 8 former CCG areas. You probably saw a good glimpse of it actually when we had that presentation on community services a couple of boards ago. So we've got our work cut out here. What we've done so far is we've created from April a commissioning resource group that is putting a framework around all of this and starting to work through the issues. And I've also consolidated most of the main commissioning areas under Craig Harris, and those that sit outside of it report to Craig on commissioning to get more of a grip on this going forward. But I think it is very much a work in progress. And I think in due course we might want to explore the governance side of that too, about whether there need to be some changes there, just as we did with primary care going forward. So I think the words are harsh there, Jim, in terms of what's said, but there is, we have got, it's going to take years to clear through this and tidy it up, to be frank. It's not going to be fixed in a matter of months, but we are definitely aware of the challenges. We are creating a framework and we're making solid progress, but it's a lot of work.
Thank you. On the point that Roy raised from the Finance and Performance Committee about long waits in the emergency department, Maggie, perhaps you pick that up when we get onto the performance report later. And there are a number of items that have come out of the alerts that we just need to keep track of, to pick up, to fit into future agendas. Thank you all. Let's move on to the joint forward plan.
Sorry, it's career limiting, isn't it, interrupting the chair. Can I just offer some verbal feedback from PIAC? Because I know that it was blank, but I have been given some notes, and it's just a couple of points that are pertinent in terms of the agenda, just to strengthen something, if that's okay. Thank you. The 2 alerts that came through, one came through around dentistry, so as to the point around quality committee. So there is feedback through the complaint service that access to dentistry is an issue, particularly in one of the Cumbria communities. And it was the reason why I'm sort of mentioning it, just so it can be captured in minutes, is I think that point around access to dentistry, if a report comes back to board, it cuts across quite a few different committees. So obviously primary care can look at the contracting, but PIAC has that view around patient experience, and quality has also looked at it. So it's just to anchor it in terms of when the primary care committee have oversight, a report needs to come back to board really to make sure that it's all integrated and brought together by the primary care team. And then the other point just to mention is that the PIAC did look at the joint forward plan and the engagement that had happened around it, and they did, while they were assured on the overall process, and I know it's been picked up in a later agenda item, which is why I've sort of mentioned it, there were some points around how that should be strengthened moving forward. So I do just need to sort of alert you to it through this process, and that those improvements would be picked up.
Thank you, Debbie. Kevin.
Yeah, I'll do a double act with Craig. You've seen this report before. We're back in March. We've done the engagement rounds with health trusts, with partners such as the local authorities, and most importantly with a series of engagements with the public. A number of changes have been made to the report. Craig will take you through some of the major changes, and really it's here for formal sign-off so that we can get on and move forward. Craig.
Thank you, Kevin. Thank you, Chair. So yes, so the joint forward plan's here for approval today. Just a thank you to Carl Ashworth and the team, I think, for producing a very detailed and comprehensive document. The actual plan itself is also attached, and happy to take any comments or questions on that. So as Kevin said, the plan came in March, and we have listened and reflected some of the comments and questions that have been raised either through the engagement process or through board, and refreshed the plan on that basis. There is a requirement, as you know, for the ICB to produce this plan, but we've taken into consideration our integrated care strategy, the state of the system report Kevin produced, our financial strategy, and also aligned it with our operational plans for this year and the emerging system recovery. So we tried to ensure that this document connects to all of those elements. The joint forward plan should describe how we, as an NHS body, meet our population health needs and also our universal NHS commitments. Also, it should link to our statutory requirements and the requirements of our integrated care. So that's the context in which we have developed this. I think since March's board, we were asked to look at addressing the gaps with our RAG-rated status, and I think that's been reflected now. Part of this is because of a national requirement on how we actually assess that status and then provide the evidence for it. We wanted to do more population engagement that I think Debbie has referred to. I think there has been some further advancements and progress in this area, but not enough yet, so we're going to continue to do further work on that. And there has been some significant partner engagement. It's been to health and wellbeing boards and also a number of planning sessions for scrutiny committees within our local authorities. NHS England have also been a critical friend for us, and that's included in the annex report as well. There are 5 strategic priorities that are included in the plan, and a number of enabling priorities. So research, innovation, workforce, digital, which we've heard in other elements of discussions today. And I think they're really important to ensure that this plan can progress at pace and scale. So the next steps, we're looking to have detailed delivery plans. Some of those are already well under development, so we want to make sure that they are cited and linked to our recovery and transformation plans, as well as our commissioning. We need to continue our work with our strategic partners, and we also need to ensure that the plan is bedded into our governance. So the plan's here for review and comment. We'd like people to note the RAG status and support the next steps, and approve the plan with your support, Chair.
Thank you, Craig. Before I open up, Kevin mentioned about public engagement, and can you give us a sense of how that worked and what we learned from the discussion with the public?
So in relation to our public engagement, if I just... So with our public engagement, we wanted to test out elements of the plan with regards to how it linked to our integrated care strategy and the priorities that were described in that plan. So Carl and the team did a huge amount of work with our engagement, there's a number of existing engagement forums that we wanted to go through. Some of those arisen from the integrated care strategy work that we've done. Some were already in place, so through our place directors, through the ICB's engagement team, and through our local authority partners. So there wasn't one size fits all, Chair. It was a whole range of engagement. And I think the reflections from the thematic areas that came out were really about how this would improve our the outcomes for people in our population, and how we could be explicit about what those measures would be for success. How we're working with our neighbourhood teams and the enhancements that we need to offer for individuals in those localities. And the way in which we work as an integrated care system, so across our partners with our community services and our acute services. So all of those elements have been reflected within the plan, and I think a really comprehensive report, as Debbie alluded to, went to that particular committee earlier to talk about the engagement that we've done to date and the further engagement that we want to do going forward.
Thank you. Carl, sorry, Carl, yeah, anything you want to add? Thank you. And Kevin?
Yeah, just it just shows the challenge of engagement on a complex document that's looking 10 years ahead, and it's comprehensive. I guess the public rightly are sort of saying, what's in it for me? That's the all-important question. And I think what we tried to do in the plan, I think it's still a work in progress, is to this concept of the pledges was an attempt to answer that really important question. But I think it's probably just a good lesson, isn't it? It's quite difficult to cover such a big comprehensive document and sort of put it into how it affects members of the public in really simple terms. So yeah, I think we did try and do that. We've got more to do going forward, but I think the team should be congratulated in our first year in producing what they've done.
Yeah, absolutely. Thank you. We're asked as a board to consider the plan again and approve. We've got Jeff, then Roy.
Thank you, Chair. No problem with the plan at all, and it's a nice read. Just, have we got a framework for how we will know how we're doing against the plan? Have we got, how will we know if we're sticking to the plan, how well we're doing, which areas were strong and which areas were weak? How will we report back to the board? Have you got something set up to visualise that for us in the future?
Thank you, Jeff. So yeah, we're ensuring that the delivery plans are going to be monitored, and then we're going to agree those metrics for regular reporting through committees back to the board. So I think it's fair to say that they're still under development in some
So it's work in progress.
But there are some clear elements that relate to the plan regarding the priorities that Carl's just described. They will need an evidence base to ensure that we've delivered those, and they'll be a part of that oversight that we will do in relation to the monitoring of the report. And I'm presuming we'll need to bring back a formal update regarding progress to the board next year.
And Roy?
Thanks. Thank you, Chair. We did discuss the joint forward plan at the recent PIAC committee, Public Engagement and Involvement Committee, on the 28th of June, and there's a couple of points that were raised in that discussion, and one was that this engagement had quickly followed on from the integrated care strategy engagement. I think we need to think about, when we're doing these engagements, about how we time them, really, because sometimes there's a confusion amongst the public about what we're actually consulting on. So I think it's really important that we think about that for future engagement strategies. We also discussed the issue that the public had raised about community-centred services. And we're recognising that some of the services do need to be centralised due to the workforces and the financial challenges that we currently experience. But I think the response that we got was that the public like community-centred services and would prefer to see those rather than have that centralisation that we see sometimes. And I know that that's part of our integrated care strategy, and that's what we're expecting to be doing in the future. There was also, I think, a point made about delivery of services. It was great. I think the public thought were happy to see the plan, the joint forward plan, but they wanted to see a quicker delivery, I think, of services within their area. And I think when we're talking about delivery, it's about ensuring that we do that in a timely manner. When we're coming out with these plans, I think we ought to include in the plan this is our expected timescale, how we're going to deliver that plan, how we're going to deliver those strategies. Because once the public know that, I think they're more comforted in seeing and able to support the plans that are going out. So I think the plan gave us a better idea on how we need to work on the transformation aspect, and I think that was important for the public as well. But the public did say to us as well, and it was raised by our Health Watch representative at the meeting, that a number of the respondents actually strongly disagreed that they lived in a healthy community. And I think that's really important actually for us to recognise as a board. And we asked that that be reported to the People's Board actually, so for discussion as well. So I think some important aspects there about that plan that were, that were brought forward to the Public Engagement and Involvement Committee, and a really good and broad discussion about that that was full of rich comments, I think, that came from the members around the table. Thank you, Chair.
Thanks, Roy. Very good. Abdul, please. Sorry. Yeah, Abdul.
Thank you, Chair. On behalf of local government, really, I'd like to say that we welcome the joint forward plan. Basically, it's actually been to our respective health and wellbeing boards, as has been mentioned, and it has a strong focus on population health, prevention, integration, and community services. We also welcome the short, easy kind of read version, really, which clearly is made the document kind of accessible in terms of equality, diversity, and inclusion. The aspect really that I would like to raise really is in relation to the implementation aspects, which have been described really by my fellow speakers. It would be great if we could ensure that the joint forward plan is actually integrated with some of the place-based partnership kind of ambitions and priorities, so that in terms of actually the delivery mechanism. So that would be a key point really for us within local government really as well going forward. And I think the whole thing really around measuring that over a timescale of the next 10 years, it would be good to get some quick wins in there as well in terms of how integration around some of the aspects that we're describing at the board are actually being practically kind of delivered in terms of our joint investments. Thank you.
Thanks, Abdul. Very helpful. Jim, then Sarah.
Thanks, Chairman. I've got a few relatively minor points, but I'll pick them up separately with Craig, if that's okay. I suppose that the bigger point I would like to pick up is around the fact later on the agenda we're talking about the board assurance framework and our strategic objectives. Our strategic objectives do not appear in this report. We've got something called strategic priorities, and whilst people might not all like what we've agreed as strategic objectives, we have actually agreed them, and I think they should feature in this document, personally.
Yeah, I agree. Thank you. And Sarah?
Yeah, I just wanted to build a little bit on what Roy said and take it back to the PIAC discussion, because I was at PIAC. I think, for me, what I heard from the public feedback that we got, building what Roy said, was great document, very, very ambitious, lots of complicated language, ambitious, complicated language, community-centric, world-class care. And actually, if you take it back to Ben's story, often in my experience working closely in co-production with patients and the public for a long period of time, is often what they want is more simple than that. They want to be able to access care at the point they need it, close to home. They want it to be joined up, easy to navigate. So if we go back to Ben had a problem. He knew he had a problem, the family knew he had a problem, but getting access to the service timely and then joining those services up was tricky. And I sometimes think documents like this, and I know it's not, we have guidelines on these documents, you have to do it, but I think, we go for this really ambitious thing when actually, if you're a user of services, you often take for granted that you're going to get world-class care. You should do with the NHS in the 21st century. A lot of our care now is evidence-based, outcomes are good, but actually what people want is to be treated with kindness and compassion, access services when they need it, and not be bounced around services. And I think that's the feedback that was coming back from the public. This is great, but what we really, really want to see is, as users of services, we want to be able to access things close to home. We want to see delivery, the things that are bothering us, not living in a healthy community. Stories like Ben, we can't access care easily. I think that's the real test. Jeff asked, what's the test? I think if we start to see less stories like Ben about it was too complicated to navigate a service, I think that's a success for us of an integrated care board.
Tracy.
Thank you, David. Yeah, I think thinking about this in terms of the sector I represent here, I think there's definitely a sense of really supporting the things within this joint forward plan. And it's clear that there's been a huge amount of work that's gone into it to, you know, really make sure that we're aligning things with other strategies. I can clearly see how the ICP strategies very much kind of in there and definitely got that flavour of those life courses and how we address that. I think one of the things that's coming out from colleagues is how many plans do we need? And I think that, again, goes back to the point that Roy made about the timing of consultations. How many times are we going to ask people to have an input into different plans with different nuances, different objectives that actually really all try to achieve the same thing? And I think also the sense of how do we consult and where are we going and who are we talking to? We're you know, as a sector, we're very much in demand at the moment as all of these things kind of develop and take shape. And whilst that is really a real positive that our input is very much sought and valued, I think there is a real sense of how do we organise it within the voluntary sector so we can meet all of these needs. And some of the things that we're talking about, some of the other strategies, so, you know, working with James around the workforce development, coming to us as a sector and using some of the mechanisms that already exist is something that I would really like to see as we go forward with some of these strategies, rather than looking at ways in which we can reinvent some of that consultation. So, you know, we're really working on how we do that, aren't we, James, around the workforce input, knowing full well that you know, the workforce around the voluntary sector have a key role to play within developing that strategy across health and care. So really just, you know, around coming to us as a sector and looking at how we can kind of work collaboratively to develop this going forward, particularly looking at kind of the public facing, the next step around having that kind of public facing document. How can we help shape that? There's lots of things happening in our communities that you could come to already. Thanks.
Thanks, Tracy. Really important point for us to take away, I think, as we think about, you know, how we continue to operate going forward. And Jane?
Thank you, Chair. 2 points, really. One is to reinforce the comments that have been made about communication. So I was telling my husband this was on the agenda and he said, "What does it say?" And I really struggled to answer that. And I think that's what we're talking about, isn't it? How do we convey the essence of this such a fantastic comprehensive document? The other one, and I'm not suggesting any of the words change, but probably what the document doesn't convey sufficiently well is what will be needed in terms of working differently and culture to achieve this. It's a little understated, and I think this shift to integrated working system working, people working in partnership, not just working in silos, thinking about, you know, wider than their own organisation, bringing in wider partners, innovating, doing things differently, not doing things the way we've always done them. That requires some kind of mindset shifts and some ways of working that are quite different. And I think as we take this forward, I think if we can find a way of kind of saying that more, almost as though to make people aware that this is not the way you've always done things, I think that we would benefit from that.
Thank you. Number of points. Craig. Now, Jim, I'm presuming that the points you want to pick up with Craig outside of the meeting are in the marginal gains rather than the fundamental reshift territory. So on that basis, that process can continue. We support the plan. I still struggle a bit with, I don't know, finish the discussion on negative, I still struggle a bit with this plan on a page palaver. My point's proven by the fact that we say we've got a plan on a page, then take 70 other pages to explain what it means. But the serious point in that is that, you know, the way in which we communicate and engage all of this is really important. Good work, Craig, well done. Right, I'm going to take Chairman's privilege to bring forward the short break. And for those, to avoid variation in interpretation, short means about 8 minutes, please, and then we'll come back and crack on with the place integration deal. Thank you. Right. Thank you. We collectively, we need to improve our use of microphone techniques. Okay? So, no, I'm not the right example for this, but when you're talking into the mic, the right distance away from the microphone. Secondly, when you're doing it, don't turn your head around to the side like that, because it sort of loses, okay? There'll be a video on YouTube to help. It's a serious point. We need to do. We're in danger of not being as well heard as when we didn't have microphones. So let's all concentrate hard. It's a message to myself. We'll concentrate hard on this during the next part of the meeting. Thank you. Place integration deal next. Welcome Karen, Louise and Claire, three of our directors at place level, to help lead us through this discussion. Kevin, are you kicking us off, please?
Yeah, I'll just say a few words. Really pleased that we've got our place directors here. Jane Scallagher would have been here if she could, but couldn't make it. It's a really important milestone today. We've discussed it in workshop format with you already. I guess the key thing is, one, if we're going to become a world-class community-centric health and care system, we have to strengthen the community side of how we provide services, prevent ill health happening, promote good health, have really proactive primary care services, have integration with health and care, etc., etc. And if we're going to do all of that, that's going to happen at place and at neighbourhood level. So this is a really important lever for realising actually the joint forward plan that we were discussing earlier. So really pleased to bring it forward today. I guess for our discussion, we've got a 3-year programme that covers all of the big ticket items that are in our non-hospital budget being effectively delegated to place. So areas like primary care, continuing health care, community services, the Better Care Fund, population health. These are all the big ticket items in our non-hospital budget. Does that feel on the right lines? Is there anything missing? Is there anything there that causes concern? I think Claire's going to say a few words in terms of the report, and then we can open it up for discussion.
Thank you. So can everybody hear me well? Okay, thank you. So a little bit of background. So this document, the paper and the slides accompanying it, the place integration deal, has been developed through a range of partnership arrangements. So lots of discussion with ICB teams, local government, providers, voluntary sector, Health Watch. And it's been built on a history of joined up working in Lincs and South Cumbria. So we've referenced a shift from 5 places into 4. Again, this is building on the work that we've done previously. It focuses on improving lives of our local communities. So whilst feeling like a bit of a technical document, actually it's about improving lives of our people and wrapping services in an integrated manner around individuals and communities to meet their needs, not necessarily the needs of the services. So I think Ben's story at the start of the board meeting, that's part of our ambition, is to make sure that our people experience an integrated pathway where it's seamless and it's delivered based on what they need. Ben and his family knew what they needed. What he didn't get was the response that he required from the services. It's the next stage, as I say, of our journey, so built on experience, strong partnerships. It will evolve over time and it will deepen integration. So it will deepen integration in places across our providers, across our partners and with our people. And we recognise there's more work to do to involve and engage and co-produce the next step with our people. But this has been built on feedback over years, actually, of people telling us that our services aren't aligned or integrated, that they tell their story multiple times and that there's gaps and there isn't a strong enough interface. There's lots more work to do. So again, this is the next stage of the start of our journey. And the deal starts to define the why, the what and the how we will integrate within our places. It recognises, as I say, this is a journey over a period of time. It starts to define the scope of what we anticipate will be included within the place integration deal. but also recognises there's a lot of work and a lot of delivery already taking place within our places, focusing on reducing inequalities, integration at a neighbourhood level, improving access to community services, continuing healthcare. So there's a whole load of things that we are already doing. This framework will help us to deliver better together, but also recognise that some of these areas need to be delivered or developed across Lancashire and South Cumbria. So a strong connectivity to the recovery and transformation plan. It then starts to talk about the how. Within that, there's governance arrangements, so moving towards joined up partnership arrangements where we've got true integration, but also permissions to delegate and make decisions as close to people as possible together across, initially probably across the ICB and local government, but also then with our wider partners. It starts to talk about performance and how we will measure the impact. And following our discussion at our board development session, not just on metrics, but also what does that mean for people. So again, a lot more work to do, but this is about measuring the impact for people as well as measuring the impact for our statistics. It then talks through that three-phase approach of our governance in development, in shadow, and then into delegation. So, as I say, an evolving journey, learning, innovating, doing something different. We do reference in the risk section the need to change the way that we do things and that focus on OD and culture. You know, most of this is about how we work together as partners and how we build relationships in place. If you get the relationships right, everything else follows. And we are then able to, you know, get moving, get things delivered, but also learn from our own experiences and those of others. So I'll leave it there.
Thank you very much, Claire. Louise or Karen, anything you wish to add before we open up for discussion?
Let me check that people can hear through the microphone. Okay, thank you. I think we've heard a lot this morning about getting the basics right. We can't get the basics right so that people can access services. They would choose to access services in the way that works for them, and that the response is one that's effective for people's health and care outcomes. Then we're not going to get the rest of it right. And the beauty of the place-based partnership is it brings a much wider perspective in. So again, those wider determinants of health, housing, employment, relationships, etc. It allows us to bring together work to support our populations around those areas too in a way that we haven't. And I suppose finally for me, if we simply concentrate on knitting our existing plans together, we're not going to achieve all of the things that we need to achieve. There are some things that we really, really need to do very differently, and we need to make sure our population's part of organising and shaping how we do things.
Thank you.
So probably what I'd just add is that we are judged on what we do rather than what we say we're going to do. And I suppose it's just to give the board some assurance that whilst today is probably a momentous occasion in making this decision, it's to give you some comfort that work has been going on for the last 12 months. We have taken some decisions and we are already executing some plans in an integrated way. And one illustration I would give in the context of the financial challenge, that for the probably first time ever, as councils, we have come together to actually jointly commission some of the services that we know our public rely on in the community. Why is that significant? Because it actually also is enabling us to stabilise the care market, who have previously had to jump to multiple tunes and are now saying, actually, I'm just responding to one, and that we are driving out best financial value, which we've got a responsibility to do. We are custodians of this public money. So although we're taking this decision today, I just wanted to assure you some decisions have already been enacted, and we're starting to see the financial benefits as well as what I would think are improved outcomes for the public.
Thanks, Louise. Thank you all. Right. Thoughts, views, comments, please. Are we going far enough? Are we going fast enough? We'll go Sheena, Jeff, Jim, Kevin to start.
So just to begin, I think this is very, very appropriate that today on the 75th anniversary of the NHS, and I'll try to not say this too many times today, to actually bring this, because I think this is absolutely fundamental to how do we really start to do what Bevan envisaged, which was to improving the outcomes for people and for people to live healthier and better lives, and actually bringing together place-based integration and actually starting with where people live their lives in their community and bringing everything around them, I think is absolutely key to doing that. So it's with great joy that I see this integration deal here today. And I'm also really pleased to hear that what Louise is saying around what's already been achieved. And I think that, again, shows that people are now starting to use the opportunities that there are through the integration, through the ICB and the ICP to start to make those differences. I think your question is very spot on, Chair, about are we moving fast enough? I will admit that I am very keen that we actually use the opportunities there are to this to actually make significant change for people. And I think having got these things in place today, I think linking back to the joint forward plan, there's some key things in there that we would want to see that the place-based integration is able to accelerate those things happening. So I'd probably say let's see what we can do more in 23, 24 and 24, 25. Thank you.
Thanks, Sheena. Jeff, next, please.
Thank you, Chair. Yeah, really welcome this. It's long been our strategic direction in the ICB and the ICS to work through places. So I'm really glad to see this happen today and happy to support it. I think the fact that this paper has now appeared is a sign that we've moved on, and we've now got places starting to mature from a concept to a reality, but noting there's a lot to do still. And so this will happen incrementally over the next year or two. So there is a certain amount of need for pace. But there's also a certain amount to get places right. And I think all the directors know that. I think they're self-driven and independent people who can do that. So I've got confidence in that. And I just want to say, I think places are the glue between neighbourhoods and system. So we can never, as a system, deliver into neighbourhood teams. Will do a lot of delivery coordinated by place, especially around the things that place will do well, like inequalities, improve community service, etc., etc. That's all in the paper. So, but I also think it's not just places about other partners, not just health. And I think it's not just about how they respond to us as an ICB, but I think critically to the health and care partnership and the integrated and the health and care boards. So I think we've talked about having too many plans today, but the health and care partnership has a strategic direction, and I think we need to be mindful of that, because I think that's an important place, an important body, let's use that word, an important body that should drive some of the things that places do. So really welcome it, happy to support, glad to see it develop further in the next year.
Thank you, Jeff. I've got Jim, then Kevin.
Thank you, Chairman. First of all, I support this, fully support this. I think it's a good way forward. Does it go far enough? Your first question. Jeff just mentioned about integrated neighbourhood teams. I want to see it perhaps more linked into how this is going to work with integrated neighbourhood teams, and then see the kind of the broader system and how that's going to function collectively. Does it go fast enough? It never goes fast enough for me, actually. So I would love to see this moving forward more quickly. We need to start to see action. Pleased to hear that you've actually achieved this kind of joint working on developing a service specification. That's great, and that's the sort of thing we want to hear about. Two specific points. One is, I know we're in a kind of cash-strapped situation, but we need to make sure that the places are adequately resourced, and I have made this comment previously, but we need to make sure that there is a sufficient team to take this agenda forward, because it's no mean feat to achieve what's set out in this document. And if it's under-resourced, it's almost doomed to failure from the start, and we can't allow that to happen, because it's really crucial, I think, that we fund this appropriately. And the second point is around inequalities. We will have discretionary money to give out, one presumes, and it would be helpful at some point to discuss how that will happen, whether we will build some sort of additional factor in to allow for inequalities within a specific area. So we've seen this core 20+5 and things like that. Whether we would take advantage or take that into account in distributing money is a discussion we need to have at some point.
Very good, thank you. Kevin?
Thanks, David. And as colleagues have said, really supportive. I think the document's very rich on ambition and absolutely takes us in the right direction. So congratulations to everybody involved. Really good to hear from Louise in terms of the care market and the work that's going on. The bit that I suppose I'm being really selfish now, the bit that I'm not too sure on, is what's this going to mean, say, over the next 12 months, and how this is going to help and support, particularly going through next winter and wrapping around our systems to keep our systems safe through winter. We know that place is absolutely fundamental in terms of how we work with our communities, how we support flow, how we keep our communities safe through winter. And I think that richness and that detail needs to be worked on very quickly. We're actually thinking about winter already, aren't we? And we're planning for winter already. And it felt last winter that it was quite isolated in terms of the lack of place input. So really welcome this, but really want to move place on very quickly, and particularly about the support that we can have through next winter.
Thanks, Kevin. Sarah, then Tracy.
Yeah, thanks, Chair. So, like everybody else, welcome the paper. It's essential. It's an essential part of integrated care boards. And I just wanted to build on a couple of the points already made, and then to answer your question, Chair. Obviously, rightly at this stage, coming to board for agreement, a lot of the content of the paper is about the process, the governance, accountability, what we're going to delegate. In my experience, and if you look at successful integrated care systems across the world, often they started with delivery and just getting on through goodwill and doing something. So I actually think what you could do faster at pace within each place is start to just do some things together that might not need a formal delegation. And I think there is pockets of that going on, but it would be really helpful to understand what that is. And some of that is about, so some of my questions are, so who is in those place-based partnerships? Have we got all the key partners around the table? And from an NHS point, it's not just the Integrated Care Board, it's the providers of NHS services. And then if you take our providers, do their operational managers and frontline clinical teams understand this? Because some of it is about empowering those frontline teams. Again, if you go back to Ben's story, just to do the right thing for the patient. Don't worry if you've not been commissioned to do it. We've lived since 2012 in a system that is very much, if you're not commissioned to do something, you can't do it. And what the integrated care agenda is about is actually teams coming together and doing the right thing for the patient or the resident that's in front of them. And I think we could go faster on freeing up, empowering and freeing some of our frontline teams to just come up with some things that if they work differently together would help. And I think that would then answer some of Kevin's questions about what's going to be different. So I think the governance and the process a bit harder, and that might need to go at the pace it's going at, but that doesn't mean within each of the 4 place-based partnerships you can't, with just goodwill, agree some things that if you worked in that way together in Blackpool or in parts of Lancashire, in Blackburn with Darwin, we could actually move some of those things quite quickly.
Thank you, very helpful. Tracy, then James.
Thank you, Chair. Yeah, I absolutely agree with the things that people have already said about this feeling like it's moving in the right direction. There's a real sense of opportunity with this. I think also I'm really sensing some joined up connections between health and wellbeing boards, between things like joint strategic needs analysis, which is so vital when we're looking at how we plan priorities and how that data is so important to align what we do with the needs of communities. I think also kind of going forward, looking at how we really kind of embed some of this work, I think there are real opportunities to do this. And I think also, some of the things that Karen picked up on is like music to my ears, because we really do need to think about those wider determinants, the things that, are barriers to people becoming healthy, becoming well in our communities. And I think what this sets out is a real chance to really think about priorities. In Blackpool, we're talking about housing, absolutely front and centre as an issue that is impacting people's lives day in, day out. And I think if we can look at it in the round when we think about where resources go and think about how we can affect change in some of those areas for people, then we will achieve some of the ambitions that we've talked about for the last 12 months. So really welcome this and really think there are some great opportunities in this. And, you know, we really do not need to forget that health is much more than goes on in the health service, and I think that's what this does.
Very good, thank you, Tracy. Got James then, Sam.
Thank you, Chair. Yeah, I just wanted to pick up on a couple of points. One that Karen mentioned. So we know that employment, local employment, is absolutely a key priority for Place, but it's also a challenge. And we know that the only way really that we're going to get to start to fill some of the really critical gaps that undermine our services is to improve our employment as an anchor at Place and to really promote the employment of local people. So this is really exciting in terms of our the way that we'll do that and the way that we'll operate. We know that the apprenticeships, really moving forward on apprenticeships, it's a key part of the long-term plan that came out on Friday. Again, we can do that better at Place. So whilst we're developing a 5-year workforce strategy for the ICB, actually there's going to be very dedicated and focused plans for delivery across each of the 4 places, and there's already work and at different levels to set up specific workforce forums in each of the 4 places. They will work closely with the People Board, and in fact, over the next few meetings of the People Board, we're starting to do deep dives with the place leaders into each of our places. The July meeting, we're starting with South Cumbria. So I'm seeing really great alignment here. And to pick up a point that Jay made earlier around OD, again, there's already been some good OD work done in each of the 4 places, and that's going to carry on. Because that's a critical part of developing them. So this feels absolutely like the right way of tackling one of our biggest challenges, which is local employment and filling some of the really critical capacity gaps we've got.
Thanks, James. It's very good. We've got Sam, Roy, Chris, Ibby. I should just have gone round the table. Craig.
Thank you. And I guess I just wanted to say something about the finances in here and the delegations, because I think, you know, it's totally supported by me and I guess all of the board really, and we're hearing and we fully support this. And I think we had a really good meeting yesterday, didn't we, to start talking about what this is going to mean. And in the paper, it does talk about some earlier delegations and doing it a step at a time. I'm really comfortable with those timelines that we're starting to put on, but I do think we do need to get the resourcing right. It's a really important, because really we've got these fantastic place leaders, but they haven't got much resource around them at the moment, and we need to make that happen. But to make that happen, we have to really make sure that we're clear on our operating model, what we're doing in terms of our own structures, and making sure we're delegating safely over the next few years, because I'm really passionate that this is the right thing to do, but we need to do that safely in light of our financial challenges. You know, we had the start of the meeting with Kevin talking about how we had to, you know, we've reset Place, but it's not just the place, it's actually the ICB itself is very new. We're 9 months in, we're a year in now today, and we're still building a lot of things. So we need to do this in the right way, because I think if we didn't have that plan and those real clear actions that Kevin McGee talked about a moment ago, I think then we would be in danger of doing this in the wrong way and just creating different problems. So I'm really comfortable with the timelines, but it's not because we're not wanting to delegate and we're not pushing out fast enough. We're trying to do this safely, but if we can speed that up, we will.
Thanks, Sam. Roy, then Chris.
Thanks, Chair. Just fully support this plan, as other people have already commented on. And I'm very pleased to see that the principles of subsidiarity apply in this plan in terms of delivery and planning at Place. Really important, and I commented about that earlier in the joint forward plan. Just to support as well what Jim said, I think, about ensuring that the money is directed to the right places with regards to people who need that money, and I think Tracy's referenced it as well in terms of deprivation. And I think this is for the place directors to consider, but I think there's a segmented population approach needed, I think, in some of these places. The Chief Executive commented earlier about places and how we'd moved from 5 to 4 places. Some of those places are still large, though, and have a huge number of people within them. And within those populations, I think, we're seeing pockets of deprivation. And as I said just now, I think it's really important that that resource is directed to those pockets, perhaps those smaller pockets. So a segmented population approach, I think, in terms of the directors of integration at place, I think needs to be looked at. But I welcome Sam's comments. I was going to comment myself on the financial position, but I think I welcome Sam's comments that we need to have a resourcing regime quite early in this process to enable, I think, some quick wins to be accelerated. And I think that there's an opportunity here for us to show the public we mean what we say. And, we know we mean what we say, but I think it's really important that we show delivery is so important to us, and that is seen to be shown on the ground. So I think that's an important issue. Thank you, Chair.
Thanks, Roy. Chris, then Ibby.
Thank you, Chair. So it's just picking up really on Sarah's point around providers and the frontline teams being involved with place, and I think to give some assurances with LSCFT touching all places, this is probably the first time I've heard frontline teams and networks talking about place and the discussions that we're having at place. I think really that's just a credit to the place directors really that we've got and the work that they're doing and reaching out into providers. So, thank you.
Thank you, Chris. Excellent. Ibby, and then last word to Craig.
Yeah, thanks, Chair. Just a quick question around the metrics and the measurement of success. So there is an initial list of metrics that we've got here. And then there's a comment on that same page that there's still further work to do with residents and partners to scope some of that out. So just your thoughts on what the timelines are looking like for firming those up. And given some of this is really kind of big integration stuff that we're trying to pull together, how we make sure we've got the right metrics. I think that's quite a tricky piece there. And also where we expect to monitor these. Is it going to be in Maggie's reports going forward, or is the monitoring going to happen elsewhere?
Thanks, Ibby. Craig, I don't know if you can pick some of that up now.
Yes, I'll try, Chair. Thank you. So just wanted to endorse what Jim and Sam both said about resources, and with my expanding commissioning portfolio, it'll be important that that commissioning is aligned to place, and we really want to make sure that that's done. I remember my very first board paper, Chair, where you asked for faster progress on our place development, and I'm hoping that today you've seen some of that progress come to fruition. I think what we've not done, just picking up Sarah and Chris's point, is probably capture where there is a lot of actual delivery through an integrated way. And I think some of our reporting does need to measure some of that integration that's already happening. I think on Ibby's point, I'm not sure it would necessarily fit with Maggie's reporting, but we did have a place development oversight group that Jeff chaired, and actually I think that needs to transition into a place integration delivery group where we can monitor that progress and bring reports back specifically related to place development and the delivery of the integration deal, because I actually think that's something that we would want a greater focus on and spotlight. So that's going to be some of the proposals we have with the Directors of Health and Care Integration. And just my last comment would be, we had a really good meeting, as Sam alluded to yesterday. I think we need to refresh our place readiness assessments now based on this deal approach, where regards where people are in relation to their readiness for that delegation. So that's something we need to agree on. The extent of that, there are multiple place readiness assessments now. MERS Internal Audit have done some, the NHS England have done some, we had one previously. I think we need to agree on what that looks like and bring back a report on our state of readiness for each of the places.
That's excellent, thank you. Well, very positive discussion for the three of you. Various points in the debate you've been described as ambitious, driven, fantastic. It's the first time the finance in our 12 months of existence, the first time the chief finance officer has used the word fantastic. and it was about you. So the ambitions are high, the expectations are high, the stakes are high. Really, this is just so crucial to the success of us as a system. And as you can feel from the discussion in the board, there's a real energy and determination to support you in your work and to create the conditions that we can do all the things that are set out in this paper. I think it's a fantastic piece of work, and we look forward to working now in this way going forward. And Jeff, I think Craig's suggestion about the oversight and so on is a very good one if you're happy to take that on. Yeah. Excellent. Thank you all very much indeed. Integrated performance report.
Thanks, David. Scared to move my head the wrong way now, so I hope everyone can hear me. I'm going to take the paper as read, as usual, but I wanted to start by picking up on something that we talked about at the last ICB board meeting, when a number of colleagues mentioned how do we really as an ICB start to get into more detail about the unwanted variation that we see across the breadth of this report. As exec colleagues, we've had the opportunity now to consider how do we actually really get alongside our provider organisations to look at all of elements of their performance, but particularly how do we actually start to be able to focus on the drivers of that unwanted variation. How do we actually share good practice from the organisations where perhaps they are maintaining a high level of performance on some of the metrics that we have to perform well on? And obviously, how do we assure ourselves? So as we move into Q2, we will be seeing the assurance element of the role of NHS England North West team passed into our ICB. And as a result of that, we've been, with David and Sarah, we've been looking at how we can actually start to move into that area of assurance in a more formalised way. So we have agreed that as we move into July, we will move to monthly individual provider organisation integrated assurance meetings. Those meetings will be chaired by either David or Sarah, and in attendance will be senior officers from the ICB, including Place, and from those provider organisations. We have a responsibility to assure ourselves on the soft system oversight framework scores that not only our providers have, but also our own organisation. These meetings are designed to be able to allow us to really get into the depth of the performance, not in the way that I feel, and I've reported at this meeting previously, that we're commenting or spectating on performance, but to really understand what the drivers are and to look at our role in supporting the providers to address those issues. So I don't want colleagues to think that there were statements that were made and that we haven't, as an executive team, been focusing on them. The following paper on the agenda is going to talk about our proposed approach to recovery and transformation, and it will touch on that those integrated performance meetings will report into the recovery board for a time-limited period. The reason we're going to take them down through that route is so that we can absolutely triangulate what we are doing from a performance perspective alongside any work that we may be doing in transformations, system-wide schemes, so that there's no untoward consequences that we are not able to bring together under the umbrella of one particular meeting. So we'll have an aggregated report from the integrated assurance meetings that we can share throughout the other committees, but particularly through that recovery board, David, that you'll be chairing, and up through to this board. I hope that moving on, it means that we are able to really understand some of that variation here and be really clear on what our responsibilities of an ICB, what are our responsibilities as the ICB in helping to mitigate that. So if I move on into some performance highlights, I'm not going to repeat everything that's in the paper, and as Roy said, we continue to monitor performance through the Finance and Performance Committee. I do want to just pull out a couple of highlights though. And I think as it is a very special day for the NHS today, I do want to convey my thanks to everybody. A few pages of a performance report really do not convey to people just how much hard work our frontline staff across all organisations and partner organisations put into the NHS functioning on a daily basis. And during May, across our system and many parts of the country, we've continued to operate in a very pressurised system. Throughout May, we've reported that we've been consistently in an Opal 3 situation. So the Opal score is how the NHS records system pressures and local organisation pressures. And it simply stands for operational pressure escalation levels. 1 is the lowest. Can't remember ever working in an Opal 1 situation outside of some of the COVID days, and 4 being the most significant. 3 indicates that a local system is experiencing major pressures which are compromising patient flow. Sounds like words when I read them out, but when you are working in any frontline situation in an Opal 3 environment, it adds an awful lot of pressure, and some of the issues that we've heard about already in the meeting this morning are driven purely because of that pressure that people are facing. During May, we did deliver the 4-hour ED standard though, and we have achieved 77.6 across our provider organisations, with some variation in that, with Blackpool being very strong, achieving 80.2%, and we've seen Lancs Teaching Hospital deliver 74.7. However, when you compare us with the Northwest achieved 73.1, and the national score was at 74%. So all of our providers were delivering better than regional and national performance, but congratulations to Blackpool, who continue to be able to perform well in this space. In relation to urgent and emergency care, I'm pleased to report that as a system, we are the only system in the Northwest region that's been placed in Tier 1 for UEC performance. This is a new tiering approach that's been applied to acute organisations and to systems. Both Cheshire and Mersey and Greater Manchester, sadly, have been placed in the category that has required most scrutiny and most support from both regional and national colleagues. So I want to just emphasise that here, because when I talk about other things in our performance report that trouble all of us who were involved in this, but particularly colleagues here, we are striving to improve what we do. We are absolutely committed to improving all of the metrics in relation to emergency and urgent care, because as we've heard today from numerous people, these are standards that really matter to our local communities. But the metrics that we're currently judged upon to determine which tier we went into were consistently delivering above the 76% for the 4-hour standard, delivery of 30-minute category 2 response times for our ambulance service, and 12-hour times that once a patient is in the ED department, we have a number of measures to determine how many patients stay 12 hours or longer. And the final area that we're judged upon is the proportion of general and acute beds occupied by patients over 14 days. So whilst it's pleasing that we're in Tier 1, it does recognise a huge amount of hard work that's delivered consistently. We recognise that on a local level, achievement of Tier 1 does not satisfy our ambitions or the needs of our population. We will be focusing one of our system-wide transformation work streams on urgent and emergency care. And right at the heart of those initiatives will be place, and how do we deliver at place, and how does place report and work with us, addressing some of those comments, I think, Ibby, around how do we keep an absolute sight on that here. And really importantly is how, as a system, do we support ourselves across the breadth of the challenges that we see in such a diverse system. So discharge of patients, both in physical and mental health beds, continues to be a major challenge for us. Although, as you've read in the paper, we are seen as being in the top 25% of organisations across the country, but it still masks what is a very heavy burden for us and for our patients and community members. So for the weekend in the 3rd of July, we had circa 10% of all of our general and acute beds occupied by patients who no longer had a medical reason to be in hospital. That was approximately 270 general medical patients. And we had 75 clinically ready for discharge patients in a mental health bed. That, across both of those physical and mental health areas, is the highest we've been in 7 weeks. So it remains a huge challenge for us, although if you looked at it on a rolling average over 12 months, you can see that our performance continues to improve. But it is something that will have to be absolutely central to the improvement work that we are commencing. We have to do more in the virtual ward space, and we have to do more, as we've talked about in some other areas this morning, to digitally enable community members not to be reliant on going to a practice or to an ED department. I also just wanted to touch on, for the same week, with the exception of ELTH, 50% of all of our occupied GA beds were occupied by patients who had a length of stay over 7 days. So again, we have to understand the drivers of those metrics, and we have to put some resources in collectively addressing them. I'll move us on quickly because I'm aware of the time, just into elective performance. So we do continue to show progress in the reduction of patients who have got very long waiting times, and we continue to benchmark well in the use of day case surgery and for treatments and procedures. Our biggest challenge over the last month has been the impact of the industrial action. And I think I saw a figure reported earlier this week that said across the country some 600,000 procedures and appointments had been cancelled throughout the period of industrial action. We are not exempt of that in our patch, and particularly Lancs Teaching, where at times, and I know Kevin will be able to comment on this, they've seen over 200 junior doctors on strike at any one time. The impact that this has had on our waiting times is sadly quite adverse. We also have more industrial action with the junior doctors, and now sadly a consultant and very senior medical staffing planned for July. And as you'll all be aware from reading the papers and listening to the news, that industrial action has got no end in sight at the moment. I just want to pick up on the points, David, that were picked up on during the discussion. 12-hour waits, and Roy has summed up some of the discussion that we had in our last F&P meeting. So the standard we work to is that no more than 2% of our patients who attend an ED department are there for an extended wait. The latest figures that I've available, and I've quoted in the report, are for the ended on the 15th of June, where we saw 7.7% of our people who attended ED having a prolonged wait. But I also take you back into that metrics which the national team are using on whether or not we need support. And our performance in this area is not currently flagging as an area of concern for our national colleagues, although, as I've said, it absolutely is a concern for us. We see a range, again, unwarranted variation in this, and we've got UHMB, for example, for that period was recording 5% of its patients extended waits, and we saw, sadly, at ELTH, a 10% amount of patients who are waiting. A final point I want to just touch on is the mutual aid. A lot of work going on with mutual aid, and Kevin might want to pick up on that. Roy made a very good point about let's try and keep our people local. Let's move our resources to serve the needs of our communities as much as we can. And there's a lot of work that the mutual aid work stream within the PCB have been doing in that space. But sadly, at times, we do have capacity in parts of our patch. So, for example, the third CT scanner up in UHMB has capacity to do more work than it's currently doing. And we do need to work with our populations to make it as easy as possible for them to access capacity wherever we have it. Very, very final thing is we've been visited across the patch by the CQC during the last period. They have, and again, Kevin has been under the spotlight there. They have been visiting Lancs Teaching Hospital, and as we speak, they are on day 2 of an inspection at Lancs and South Cumbria Foundation Trust. I do believe from Sarah that they're in a number of nursing homes in our patch as well, and by the time we get to board in September, we should be able to give you a view of what their findings have been. But I'll pause there.
Thank you, Maggie. It's very good. I'll come to Kevin and Chris and then bring other colleagues in to add. So at a personal level, I've made note of your implied criticism of emergency care in Liverpool. Kevin, to you first and then to Chris.
I couldn't possibly comment on that last point, David, but simply to say Lancashire and South Cumbria are performing better than the other systems. Just a few points, if I may. I think it's great that the assurance framework is now moving it to ICS level, because I think we'll get much better, much more nuanced conversations. I think what's important, though, from a provider perspective, is that's not additional. We take other meetings out to compensate that, so we need to take the meetings out with the regional colleagues and hopefully some national colleagues and focus it more on the ICS, otherwise it just becomes more sort of burdensome. I think within that also, it's really important that we get quite nuanced in terms of the comparisons. So in terms of the work at Lancs Teaching, because it's the tertiary centre, it's more of a comparison with Manchester and Liverpool as opposed to a comparison with the other providers in Lancashire. The strikes are a real issue, and they're an issue right the way across the country in terms of capacity that's been lost. And we are going to be in a position, and I've raised this with national colleagues, we can bring some of this back and we can substitute for the work that's been lost, but we'll have to do more insourcing, we'll have to do more waiting list initiatives, and there will be a cost associated with that. So we need to understand what that's going to be. That obviously puts pressure on the system's finances, so we're going to have to be really clear about the capacity that we want to put in the system. Do we spend more money? Do we do some insourcing? And do we pull those waiting lists back? It's a real sort of choice that we need. Maggie noted the issue in terms of Opal levels, and that's absolutely right. We're consistently across Lancs and South Cumbria at Opal 3, but not just at Opal 3. We actually grade that, and we're at a high Opal level 3 consistently, day in, day out. So it just gives you an indication of the pressure that we're under. If I was to therefore say one thing that would absolutely help here and now and going into the winter, and linking it back with the work and the conversations we've just had on place, it is on non-medically fit to reside numbers. If we could get that down to a position of 5% across all our providers and in all our place, that would have the most significant impact in terms of patient safety, in terms of flow, and in terms of resources in our system. So if we're going to focus on one thing as a system, as an ICS, as place, it will be those non-medically fit to reside numbers. We must get on top of that before we get into winter. And then finally, just in terms of the mutual aid is going to be really important. I just caution about the notion that we can move staff all the way across the system. We need to think about the proper use of resources, and we've got fixed capacity in terms of theatres, in terms of diagnostics, and it's going to be a combination of moving staff but also moving patients to where that facility is and where those facilities are. So, there's a lot that we can do in terms of mutual aid. We can take out some of the variation, but it's not all going to be local. We have to think about how do we use our resources and our fixed assets, such as theatre capacity, such as our diagnostic capacity, in a very different way. Thank you, David.
Thank you, Kevin. It's very good. And Chris, please.
Thank you, Chair. So I would concur with everything Kevin said there around our non-medically fit patients, and 79 beds within Lancashire and South Cumbria Foundation Trust is a third of our general mental health bed stock, so it has a massive impact both on out-of-area placements, but also patients waiting in EDs that Roy mentioned earlier. And we continue to see across the system and outside of the system learning disability placement breakdowns that then come into mental health beds. And as of today, we've got 14 acute mental health beds that can't be used for mental health admissions. So that's a huge piece that we're working together both as providers and commissioners, which is really helpful. just specifically on breaches and patients waiting long periods of time within EDs, we know that is absolutely not the right place for a patient that is in mental health distress. And we've created an incident management group. So they are groups that we have created in the past. We heard about Ben and the eating disorder issues that I referred to earlier. We created an incident management group around that where it's chaired by an executive. That one was chaired by me, but the ones going forward, so we've got a home treatment team, which is going to be chaired by our chief nurse, and a super stranded incident management group, which is going to be chaired by our chief medical officer, to really look at criterias and threshold for admission and challenging our really long patients in our inpatient beds to make sure that we're improving flow to reduce the impact on our acute colleagues' emergency departments. Happy to share the performance with Maggie around that.
Thanks, Chris. That's great. Got Chief Nurse, then Chief Finance Officer.
Yeah, thanks, Chair. Just a couple of comments from me. Thanks for the report, Maggie. And I thought the balance scorecard is really helpful, so that's really progress. So I suppose just a couple of comments from me. Looking at the balance scorecard, the thing that really jumps out of you is the SEER red around diagnostics and cancer, so that is a real concern. And I know we've had lots of focus here at cancer, but I suppose it's that continuing to keep the focus on the areas that are on a downward trajectory rather than on an upward trajectory. And additionally, a couple of the table that's got sickness and vacancy rates, that's quite variable across the providers, and there's a couple of real hot spots. So again, it's how we work together and through the People's Board work and those strategic priorities of supporting those providers where, like particularly LSCFT, there's real high vacancy rates. So it's what can we do together as a system in those areas that we know are really hard to recruit to, but also on back of the new workforce plan, how are we growing the workforce of the future that are going to go into those areas that are really hard to work. So, for example, learning disability and autism is becoming an increasingly hard specialty of nursing to attract new entrants into, so we need to do that work. And then last comment from me, and I think I might have mentioned this before, but maybe, Maggie, this is something we can pick up outside. The children and young people's and maternity metrics, they represent maternity bit, but they really don't pull out. There is a national transformation programme for children and young people where there's some really focused work going on, really good work going on in Lancashire, South Cumbria. We're doing really well on the national programme on respiratory, epilepsy and asthma in children and young people and on core 20+5. And I think it would be really good for this report to be pulling out some of those key metrics because there are some really good examples of progress that our teams are making across the patch on those.
Thank you. And Sam?
Thank you. I think it was really, really helpful to hear Maggie say that although, we are doing relatively well on performance, that we're not sitting back and just standing still. And I think some of the comments that others have made, there is an absolute link between performance and finance, and we're hearing that. And I guess what we're hearing and what we're seeing is that we're doing relatively better on performance, but real challenges on finance. And I want to just frame the next couple of papers for people because we're going to talk about recovery in a moment and then some of the risks in the finances. And I think, we've got a real opportunity to work together on this. And the solutions to this are going to be system because all the things that Maggie has talked through and all the things we've been talking about here are not the best outcome for our patients. We don't want people in hospital when it's not necessary, and we don't want people stuck in beds or even coming in the first place if it's not the best place. So part of the recovery, big focus of the recovery, when you look at how this translates into finance, the big pressures we've got around finances, around that urgent care pathway are really, really clear, and that's where the recovery focus and some of the solutions need to be really focused on. Because when we look at bringing non-medically fit to reside, looking at virtual wards, this isn't about shutting capacity. This is about moving capacity to the right place, and when we do that, it's not only a better outcome for the people that we serve, it's actually an awful lot cheaper, and we have to tie this together. So I think it's really, I just wanted to make that point because this is the big numbers. When we get into the next couple of papers, this is where we are centering the big savings around, so we have to have that focus and understanding, and no one part of the system can do this on their own. This has to be a system approach to how we're doing recovery and finance.
Thank you. Jeff?
Thank you, Chair. We often focus on secondary care, and I understand why in this conversation. And there is stuff in there on primary care. But I've got a suggestion, and it's very related to our discussion today about place, and I understand now our clinical leads in place have been appointed. The methodology for looking at primary care performance is well established was well established at CCG level and indeed at neighbourhood level, and I don't think it requires any permission or delegations to ask places and their clinical leads to facilitate conversations about performance of primary care around some key things that matter to us here. And that often drives improvement. That's where I cut my teeth on prescribing performance 25 years ago, and it works when you get people together who know each other, look at the evidence, bring in the training, and I think we should look to doing that and facilitating that primary care. I know David Levy isn't here today to agree or disagree that, but I think it would be a sensible thing to start work at neighbourhood level, aggregate that at place level, and then places can aggregate that feedback to here. And I think that work could happen below board level, and we could just be informed if there was where there were problems.
Yeah, thank you. We do that, Maggie. It's a good suggestion. Thank you. Okay, so Sam, you've teed up how some of the issues here roll into the discussion about recovery and transformation and then finance. So let's run through those quickly, and then we can open up if there's more comments that people wish to make. Move on to the recovery paper now.
Thank you. I thought that's what you meant. So thanks for all the comments. I've jotted them down and I'll take them forward. I know if David Levy was here, I'm sure he would agree with the sentiments from Jeff, and it's great that Place Partners are in the room with us to be able to work with me on that. So if I move us on then into the next paper, I know that Kevin mentioned this briefly as he opened up in his Chief Exec report. And as you people can see, with the change in the name of my name template, we've made a decision at executive level to narrow down the focus of my role into recovery and transformation. And I hope in the not too distant future we're talking about that as clinical transformation, because I think Sam's made a really good point, and it's predominantly one of the drivers of us moving to work in this way, which is we have to understand, and we do understand, what the main drivers of our financial problems, challenges are. And we know that if we look back at some of the diagnostics that have been done that predate me and many people around this table, one of our biggest areas of concern is the clinical models that we've got. And I think I've said here before, in some ways we should congratulate ourselves that we are running a clinical model across the breadth of our geography. And we do that, and in some areas, as both I've indicated and Sarah's just mentioned with children and young people services, we've got some examples of doing that extremely well. But that comes at a cost to us because of the huge challenges that we've got from a workforce perspective particularly. And if we carry on over the next 15 years with the same clinical model that we've got, then we shouldn't be surprised that we'll continually come back here and talk about the financial challenges that brings to us. So part of the work that we need to do, particularly as we've outlined in this paper over the next 3 years, is to really look at how can we create a model that drives efficiency and brings the very best to our populations as local as possible, that at the same time, with the model that we've currently got, we are as efficient and as productive as possible. Now, Kevin alluded to the work that we need to do to recover some of our elective performance right now in the moment. And I absolutely support and commend the work that Kevin's trying to push in that area. However, what we have to do in this very short period in the next 3 years is demonstrate that this current clinical model that we've got is absolutely working in the most efficient and productive way as possible. So it doesn't matter that it's a real strain on resources because we can't recruit. All of the other elements to it, we have to be able to demonstrate that we really do hold our own, as we've tried to demonstrate with the no medical criteria to reside, where we're in the top 25% of the country. We have to push our game in everything that we do. It isn't enough that we're aiming for to have an improved financial position in the future due to the model changes that we might possibly make, but it's really key that we can hold our head up right now. The inefficiencies that we see impact on our communities all of the time, and so improving what we do is not just aimed at improving the balance sheet, it's trying to get things right the first time for our patients, both in and out of hospital care. So what we've tried to do in this paper as an executive team is give ourselves the ability to do a number of things. So apologies if some readers found this a complicated paper. But what we're trying to do is take over the assurance in the way I described earlier from the regional Northwest NHS England team. And we're also trying to not boil the ocean, but to distill down what are the key priorities that we must deliver on if we are going to deliver the pledge that we've made to our National Finance Director to improve our financial position, not in a way that is outwith of what is happening in other parts of the country, but to move ourselves from an extreme financial outlier to middle or better than that in the pack. So we will not only talk about what is our general performance across our sector, but we will also look at how can we improve that without any untoward consequences. Under 2.3 in the paper, it sums up a comment that, David, you made to me during the break there about how inherently complex what we're trying to do is. And if we allow it, that inherent complexity will paralyse us and stop us from improving. But the aim of this board is to try and simplify that, not to boil the ocean, but to look at the key priorities that we have got, that we can clearly see from an evidence-based perspective, and we can start to focus on them with the right people being brought together in a frequent way in order to deliver that. It will have some impact on our on only one committee, and we discussed this at the Finance and Performance Committee. No other committee of the board that we currently have should be affected. I do believe that we will be able to improve our reporting to some of those committees, but we are still going to look at what impact this committee will have on the performance element of the F&P committee, and me and Debs have had the opportunity to discuss that briefly yesterday, and we want to join with Sam to be able to progress that conversation as a result of the ask of Roy as chair of the F&P. We know we need to keep the F&P, and we know that we need to keep the focus on financially all of the impacts that we're having, but we don't want to burden that committee talking about some of the real minutiae of our performance. We believe that we may be able to do that in the integrated assurance meeting, escalating as appropriate. So it might take a little bit of fine-tuning over the first couple of months, but we have built that into a review system with the paper. The only thing the paper hasn't done justice, and I'm going to pause in a second and pass to Kevin, is some of the comments Jane made earlier about culture are absolutely not lost on us as an executive team. And Kevin wants to build into this recovery programme an OD approach so that we're actually looking and working on those cultural issues as being enablers to improve the performance that we provide. So we've really brought the paper to note here, but very happy to try and answer questions on it. But I also wonder if Kevin just wants to pick up on the OD element and the culture issues.
Thanks, Maggie. Just a couple of general points first. Big challenges, but actually big opportunities, really. So it's that balancing act. Finance very much to the fore with a 80 million pound deficit across our system, but actually underlying that, it's about culture and it's about the system. What we're talking about here is a dedicated team and a dedicated governance arrangement. It enjoys the full support of our colleagues in the system, which we've discussed it with and gone through with them, in detail the chairs and the chief executives, and it enjoys the support of NHS England as well. It's only going to work if we work together. And therefore, it's really around people and relationships, isn't it? It's not just about the numbers. And that's why we're looking at an approach which effectively tries to do three things. Have an approach to leadership development and organisational development that is earthed in what we've got to do here, not just something generic you pull off a shelf, that it deals with, if you like, some of the hard skills around, for example, data science and modelling that's needed, some of the soft skills around collaboration and personal leadership, but also explicitly building a community of leaders across our system. And we want to look at the best examples of integration that have happened across England and Wales and Scotland and Ireland, but also look further afield as well and really get the best lessons. So we want top quality support for this to move forward. So I think it's challenging, but it's also equally exciting as well.
Thank you. I want to complete the picture with coming on to the finance report, and then we'll open up. But before we do, you mentioned about how this way of working impacts other committees. I've had this discussion with Roy. We'll not change any of the other committee responsibilities until any of this is embedded into we see how it's all working. Finance report, please. I'm just using my prerogative to change
Yes,
the
that's
order.
fine. Just wanted to check. Thank you. Let me find my notes. Right, I'm going to use the word fantastic for the second time today in this meeting, I'm afraid, because I'm feeling particularly positive about a few things. But I just want to say it has been one of the busiest few months the last couple of months have just been unbelievably busy, because we've had to submit a plan that's been really challenging, close down 8 sets of accounts, and all of our provider organisations doing the same. At the same time as trying to come up with sort of monitoring and progressing with the in-year progress. And I just want to say a massive thank you. We heard this morning from Ben, you know, about, and it actually was great to hear about how, you know, we are looking at some of those corporate people that do make a difference. And on the 75th anniversary, I just want to say massive thank you to all our fantastic corporate staff, because they really have been amazing the last few months to get here. So the message is really, really harrowing, and we've got lots to do. But I just want to make that point, because they have worked incredibly hard right across every organisation in Lancashire, South Cumbria, and they often don't get recognised, but we wouldn't have got through the last few months without them, and they have been really good. So thank you to all of you out there. But this paper gives an update on the progress in the second month of the year. So it highlights the risks and focuses on the delivery plan. And following the last board, the financial plan was submitted, and we've just mentioned that that's looking at an 80 million deficit for the year, and we're taking a 3-year approach to how we're looking to sort of really turn this around, hence looking at the recovery approach that Maggie's described. And that's really important. It doesn't mean that we shouldn't be aiming for break-even, because we absolutely should. And as an ICB, we've put in a break-even plan, and the 80 million deficit plan is sitting across the acute providers. We still are being asked to, because it is it's a statutory responsibility to break even, and we're being asked to still attempt to get there this year as we progress the work. But that is where we are, with a view to how do we get into recurrent balance by year 3. So we're looking at that. So it's really important at the early stage of the year that what you see in this paper, I'm not going to go through the detail of the paper, but I just want to pull out the real risk that we want to see. And there's a high level of savings requirement across all the organisations in the system, totaling almost 300 million. So we've got about 200 million, just under, of savings across our provider trusts, and another 100 million in the ICB. And they are all backed up with plans that are developing. And what we've seen through the assurance meetings that I've been holding with the provider trusts is that the processes and the identification of plans is so much more robust this year that it's given us some extra assurance about the way that people are progressing. That we're seeing that in all of the providers that we're talking to. It doesn't mean there's not high risk in there, because it's a big challenge. It's a 5% CIP requirement across our provider colleagues. So that's really important to understand that, because it isn't without risk. But I think the process and the way that we've progressed even in the last 2 months has been really, really good. What we're doing in the ICB, and Roy mentioned it before, is we've got the sustainability group chaired by myself and Sarah. And that has leads looking at all the schemes that back up our SIP and stretch plans, and we're looking at that every 2 weeks, either through a deep dive or through a more formal meeting once a month, where we see where we're at, and that feeds into the Finance Committee. There are plans and schemes behind all of that, not again without risk. And one of the biggest risks, and I have to highlight this, is the work we're doing around the contracts, because that's the most difficult area. And I think there's still a lot of work to do that. We're not, you know, we're 3 months in and we're not seeing the progress that we need to see. So we have to be really clear there is risk around that. So that's a big chunk. It was 30 million of our savings plan. So we need to really, really progress with that. But there's been, I suppose, the bit that where we got from sort of in terms of balancing the plan, we put a £72 million stretch into the system, which was really about the recovery that we've just been talking about. So it's really important we understand that outside of all of those SIPs and QUIPs, there's still a stretch there, which relies on us looking at that sort of capacity, looking at, and that's the discussion that we had in the board to sign the plan off. So it's really important now we translate that into really tangible, robust plans into how we're going to get that out over the next few months. So I think it's just the actions that we take now. I'm being asked to go to monthly meetings with our NHSE colleagues regionally to really assess where we are. We had a meeting with the National Director of Finance recently, last week, and you know there has been good progress at month 2, but we're very early in the year. What we need to see is that ongoing stability of that, and then being really, really clear on the assurance of the plans as we're developing them over the next few months. So I expect that we'll be asked to provide more and more assurance as we go through the following months on how those plans are materialising through the work of the Recovery Board in particular. But at month 2, we are £6 million off where our plan is. What you might notice is that the plan profile at the moment was a 44 million deficit plan. It's not a hockey stick, but it's reducing over the year. So what we're looking at is that coming down so that we meet the 80 million plan at the end of the year. So it's stacked higher at the beginning of the year, but it doesn't just go like that. So it's all in the last few months. And I was trying to think of an analogy that wasn't a hockey stick that went more like that. So if you think of one, tell me, because I keep trying to describe it. But it is more of a slope upwards rather than a big hockey stick. So we need to make sure those plans are following that trajectory as we go through the year. Tipped up. Okay, thank you for that.
The facts in the paper are that we've signed up to being no more than 80 million overspent at the end of the year, and after 2 months we're 50 million overspent. What was the mood in the Finance Committee when those numbers were discussed?
Sorry, Chair, Jim wasn't there. Obviously, some concerns from... We're in month 2 at the moment, so, you know, we looked at it quite...
This is month 4, right?
Well, yeah, I know. But with month 2 figures, we were looking at month 2, but we... I was concerned on the 6 million, actually, quite frankly, because that is determined by slippage in a number of the acute trusts on their SIPs. And if we're moving toward that sort of now, I get a little bit worried about what's going to happen further on in the year. But Sam's...
We're guided by you, Sam. Is this a keep calm and hold your nerve moment or a start to panic moment?
So this is a key moment in we need to see those robust plans, because this risk becomes significant if we don't see those plans in the next month really emerging, because what we're seeing is we have planned at this stage of the year to be 44 million in deficit. We're actually at 50, so we're 6 million off. That should level out, but it'll only level out if we've got the plans to do it. Now, I'm more assured, as I've mentioned, around the SIPs and the QUIPs that we have, because there is a process behind all of that. The bit that's going to be this stretch that we put in around 72 million is going to need a recovery approach, and we haven't yet seen that. So that becomes the real risk for the board to be focused on, and hence the work that Maggie's just described becomes really important.
Thank you. Okay, look, I'm conscious I've skipped through a few items quickly. The performance report, I think on the approach to recovery we note, and we'll have more discussion as the new method gets into operation. Nothing else in the governance will change until we get to that point. But any other questions, responses on the finance or performance papers that Maggie and then Sam have introduced, please?
I think we are more or less where we would expect to be at this point in time. But this is absolutely crucial. The next 2 to 3 months is crucial. And by the time of our September meeting, if we've not seen progress, we've got major problems. So I know that a lot of work is going on. And I think the proposals around the system recovery and transformation plan are helpful. That's really got to hit the ground running, though. It's got to have almost an instant impact. So things are... One thing Sam told me, which I don't think you mentioned, is that the rate of spending has stabilised, and that in itself is a significant point. So that was the first part of recovery, is not spending anymore, in effect. And we've stopped doing that. So we've held the level of spending, and that's a positive sign. The conversation Sam's having with Trust seems to be much more positive than it was in the past, so that's also very helpful. So there is encouraging signs, but we now need to see the numbers coming through.
Thank you. You still sleeping well, Kevin?
I don't sleep at all, David. In terms, I mean, so this is a really difficult ask, isn't it? The numbers, Sam talked about a 5% cost improvement programme. For Lancs Teaching, it's closer to 7% when we take into account the systems gap as well. So, you know, the numbers are extreme. What I can say is that we are further ahead in terms of the identification of our savings than we've ever been. I've more assurance than I've ever had at this time in the year. So there is some fabulous, and I'll repeat Sam's word, fantastic work going on. It's just that the ask this year is so extreme and so far out to where we've ever been that the risk in the system is significant. And I think it's going to remain significant as we go through the year. So we will do our very, very best to get on top of this. We are pushing and pushing in terms of trying to find additional savings. But the work that we're doing, we have to do whilst trying to manage that triple aim about performance, safety and quality, as well as the finance. And that's what the providers are absolutely focused on.
Thank you. I mean, it feels, Kevin, that this is a keep calm and hold our nerve moment on all of this.
It absolutely is, Chair. I think that's exactly the right phrase. I feel we've got a good plan. We've got much, much better definition and assurance around the SIPs, around the system, and the QUIP at the ICB. There's absolutely high risk in elements of that, and I think we're across all of that. In relation to the hockey stick point that Sam was making, I think it's 40% in the first 6 months and 60% in the second 6 months. So it is a gentle rise. It's not an extreme hockey stick, but yeah, it's hold your nerve and keep a close eye on this. So there should be no surprises as we go through the process.
Okay, thank you. Going back to the performance report, the number of things to follow through that the performance committee can pick up. Look, at the last, I think it was the last meeting, or it might be the last but one meeting, I raised what I thought was a fairly innocuous point about some of the variation in access to diagnostics. And maybe the performance committee could look into it, then we look into it, and then we see in the papers now that there's some big piece of work commissioned off the Cancer Alliance and so on. We're not trying to create big pieces of work. I just made the assumption that somewhere in our infrastructure and organisation, someone would have a good grip on the different demand and supply issues in different parts of the patch. We've still not seen that, but I'm reluctant to ask any more questions. It gets 200 people running off into a corner doing an extensive piece of work. Let's talk about board assurance framework then, please.
Give a quick introduction, then hand it over to either Sam or Deborah. Look, it's a critical role for this board to have the BAF in place. Last year we did it in a bit of a vacuum in December without having the benefit of a full comprehensive long-term plan. That's now different. What you've got before you today is an updated, more refined version of the BAF. I hope you'll agree. I think it strikes a better balance between the strategic risks and the operational risks we have. We do want to follow this up with a development session, Deborah, don't we, in the autumn, so that we can look for the opportunities to improve the alignment better between the LTP and the BAF, but I think it's in a good position. I don't know whether Sam or Deborah want to add to that.
So if I can just come in, I think obviously this is the key document to ensure that the board's got a comprehensive oversight of risks, and it is shaped by the strategic objectives. So we heard earlier, and it was a good point raised before, the strategic objectives that are shaping this currently are not the ones in the joint forward plan, and we now need that piece of work that Kevin's talked about in the autumn to do that. What I would say is obviously bringing the 8 organisations into one. You can't take 8 organisations, BAFs, and go, there you go, there's the merged one. You have to redo it because it's a new organisation with a new strategic objectives and a new direction. So it has to be shaped by that. So the work we've done to develop it, and I say we, and Deborah and a team have done some fantastic work. It's been picked up in our audit report at the end of the year that, you know, it wasn't in place all year because it couldn't have been. So we now need to embed this and do the work with the board on aligning it to the joint forward plan. But I think the work and the corporate risk registers that sit behind this is some really good stuff and some really good tools now in place of capturing those risks. What we need to make sure is that we're doing this in a really comprehensive way by really aligning it to all of our strategic objectives. Otherwise, we might not be shaping our agendas at the board in the right way. So it's really important that we do that. So that's the next step.
Yeah, thank you, Sam. I think that's the key bit that we go through all the business, we have all the discussions, then at the end someone says, can we just have a quick look at the risk register? It's the wrong way around. The key change is the bit that you've described, where a comprehensive risk-based approach to our business determines what we need to be considering here at the right time. And some of our trusts do this very well. So I don't think it radically changes the agenda and so on, but it helps us connect our focus onto the things that are the highest risk in the delivery of our strategic objectives and so on. So I welcome this work now. Jim, do you think we're making progress with this?
Well, yeah, we're making progress, yeah. We're not where we should be. We're talking about it 15 minutes overdue and we're trying to rush through the item, which is really important. I think the most important bit about the board assurance framework is stepping back and assessing whether we're delivering the strategic objectives. And we're not having that conversation. We've got 6 strategic objectives. We should be debating how we're performing on each of those strategic objectives rather than just looking at the risks. So I think that this needs a longer discussion about, are we actually delivering the things we're supposed to be delivering as an organisation? And that's pretty fundamental. The other point I'd make is, while this is a big improvement from where we've been, and it's really good to see the key risks for the organisation of the board assurance framework. But you know, Kevin mentioned it earlier. A few people have mentioned it. Our biggest risk is emergency care. It doesn't feature on our list of risks. So we got our kind of key risks, and yet the thing that we're saying is the biggest risk to the system is not mentioned. So that strikes me as a rather significant gap. So I won't say any more.
Other comments, please, Debbie?
Thanks, David. Definitely welcome the framework and the clarity of sight. I think one of the things that will be really important when we look at it in the development session is how it can be kept a live document that informs the work and the focus, not only of the committees that have got that assurance role, but also broader committees as well. So just thinking about PIAC, for example, there's quite a few things that have come up that PIAC might have an interest in, could make a contribution to, or could support mitigating risks against. So one of the things I think we need to look at is having a clear line of sight where the assurance sits, but also having broader input and trying to make it as live as possible, both to staff and also to committees and board members, which will then lead to a richer document and a sharper focus from all of us.
Nibby?
Thanks, David. I think this is really helpful development, and David, I think your comments around this really driving to some extent our agenda and focus is really helpful. I think at some point when we do a more detailed review of this, just looking at the risks themselves will be quite helpful. Some are very strategic, and then others we kind of getting very operational, like the dentistry one. So we just need to get a kind of understanding of, you know, where we kind of pitch our risks and whether it's a bit of both or we keep it fairly strategic.
Everybody content with where we're at and the next steps? Thank you. And finally, scheme of delegation review.
This paper has been both through the executive team and the audit committee, and it sets out the scheme of delegation. The scheme of delegation, this sets out what this board is delegating in terms of decisions to other places across our organisations and what's reserved for decisions by this board. So the board can only make changes to this. It can only be agreed and approved. So it is approval today that we're looking for these changes. And I guess when we first came together this time last year, we had a number of schemes of delegation and we had structures that were still operating in local CCG patches. It's only now, at the end of the year, really, at the end of the first year, we've now got a single structure all brought together, all 8 organisations together. So we've had to reflect a lot of those changes. So what you'll see in there are some key changes, some of them around titles, what the changes we made to committees, presentational updates. But during the year, we've also developed some of those committees. We've had a new committee, we've had the senior leadership team put in place, and we've had our place structures starting to come together. So what we're looking to do now is to update all of that here. So this has been through, as I say, a number of processes and been discussed, and we now need to roll this out into the organisation. There are 2 things that I think are absolutely key in terms of next steps around this as well. One is then to think about, as we move on that delegation plan we talked about before with place, that we continue to review this in light of that, because it will need to keep being updated for the developments we make around delegations to place. And secondly, that the format in which this is in, this was a format that was used by CCGs previously, and it's all in a sort of Excel spreadsheet. I recognise it's not particularly user-friendly. It's not the best document that I've ever seen in terms of engaging with staff to go out and start using this. So what we've agreed to do is, following this meeting, is now that all the accounts and everything else is in, my team are going to be focused on putting this into a much more word-friendly document that can be used out in the organisation. But if the board could agree the content of what we're saying in here today, then we can start utilising it and implementing it into the organisation.
So was the discussion at audit committee well, this can only be decided at the board. Is the audit committee content for the board, and is it look at this for the board to approve it?
The audit committee's view was we couldn't make sense of it, so therefore we did not discuss it in any kind of detail. And I find it a very hard document to understand, frankly. And I think there is still some issues in there which are not clear. And I mentioned 2 or 3 to yourself, which... Yeah. But I understand also there's a need to progress this. So there's a lot of things which are kind of really important to get in place, like the change in committees and those sort of things. So this needs to progress. But it's very hard to work your way through it and make sure it's correct in the round. And I can't make almost head and tail of the things that I've been trying to look at in this document.
Any other comments? Okay, I agree with Jim. There's more work to do. We can agree the levels of delegation that are in here, but how all that translates into operation, we just need a simpler version of Sam if you keep working on that.
Okay, thank you.
I'm not notified of any items for any other business. Excuse me, covered a lot of ground again this morning. Thank you all for your attendance and your contributions. We will start the part 2 meeting at 1 o'clock.